Technology problem. Okay. Thank you. Yes, okay. Right.
Arvind, good morning.
Good morning.
Yes, sir. Good morning.
Good morning, sir.
Welcome, sir. Good morning. Good morning. Welcome to everyone. Chinnasamy, sir, good morning. Shall we start?
Good morning,
program,
sir.
Good morning. Welcome, sir. Welcome. Ma'am, Sushila, ma'am. Good morning, ma'am. Good morning, sir. Dr. Jayaraman speaking.
Good morning, sir.
Morning, respected members of our IMA, all the senior leaders. Greetings from IMA Academic Committee. For the meeting, I request our elite member, Dr. M. Chinnasamy, sir, for the welcome address. Over to Dr. Chinnasamy, sir.
Good morning. Am I audible, sir?
Yes, sir, audible, sir. Yes, sir. Proceed, sir. Thank you, sir.
Good morning, dear friends, fellow members, and members of the academic committee of the TNSP. Today it's a beautiful morning outside, and I hope everyone is in a relaxed and attentive mode to participate in this World Cancer Day panel discussion and adolescent sexual and gynecological health current focus and concern CME. I welcome you all and urge you to make the most out of this meeting. Welcome you all. Thank you.
Thank you, sir. May I request Susila ma'am for the prayer, IMA prayer and physician prayer. Dr. Susila ma'am. Good morning, Dr. Susila ma'am, for the prayer song. Okay, no issue. I'll do the prayer song. Or anybody wants to do the prayer, you can do. Sudha ma'am.
Hello. Good morning, sir.
Good morning.
Hello.
Kind request all the delegates kindly mute except the speakers and the office bearers. Dr. Sushila ma'am. Okay, Dr. Sudha ma'am.
Yes, sir.
Yeah, you can do the IMA prayer. Yes.
Good morning, everyone. I am a prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the whole healing cure beyond every greed and lure. Physician's prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guilt and worldliness, that with the simple faith of a child, I rely on thee.
Thank you, madam. Thank you very much. I am Dr. S. Jayaraman, Chairman Academic Committee of IMA TNSB. So, warm welcome to this IMA TNSB Academic Committee second virtual meeting. So, first of all, I thank our President, Dr. Sandamil Parisar, for giving this responsibility for conducting this virtual CME program through Zoom portal for all of the members from Kanyakumari to Chennai. This is one of the big tasks and very important committee. So knowledge sharing is a very, very important one. Knowledge is power, you all know very well. So every day, every month, every year, we have a lot of clinical and scientific updates. So for the practical purposes, these updates are very, very essential for our practical purposes to heal the patient. For the patient purpose, this is a very, very important thing. So for this responsibility, we have wonderful members of our academic committee. So thank you, Sandamil Parisar, President. I thank and all the senior leaders and office bearers of state and zonal vice president and the branch president secretaries, all of our brothers sisters of our IMA branches from Kanyakumari to Chennai. There are 165 branches throughout Tamilnadu. So we have 45,000 members in our Tamil Nadu state branch. So with this few introduction, so we have today's wonderful program. This program architect is Dr. N. Subramanian sir, one of our academic committee leader member, and the sir is one of the president of IMA Tamilnadu. Sir has today's Royal College examination, so supposed not to join today, so he'll be busy with the examination. So may I request Dr. Mohan Ibrahim sir will be moderating all the sessions. So today the purpose of the meeting is to commemorate World Cancer Day. So you all know very well the cancer, one of the highest top 5 causes of death mortality in the world. So today's topic of discussion is the panel discussion on common adult cancers in Tamil Nadu, screening and early diagnosis to close the care gap. This is the topic. Under this, we have an eminent oncologist, all our members of our IMA, so working in various hospital and medical colleges as oncologists. And we have a second part, we have a wonderful discussion on adolescent sexual and gynec health, current focus and concern by Dr. Madhubala Madam. So today we have 11 to 1. We are going to enjoy all the academic feast and updates from the cancer as well as the adolescent and sexual health and all. So we have this program is accredited by the Tamil Nadu Medical Council, 0.5 credit hours for the same credit point. So I request all our delegates kindly type your name, registration number, email ID, and mobile number in the chat box. After the meeting for the IMA credit point certificate, so you have to pay rupees 100 by online in the following account. The name of the account is Indian Medical Association AMS. That is the Academy of Medical Specialties. You can type Indian Medical Association AMS. The account number is 75260100001890. The Bank of Baroda and Teni branch. The IFSC code is the BARB, BARB 0. That is not O0, THENIX, THENIX. The fifth character is 0, not O. And this detail, this send the transaction detail of the screenshot to our ima@tamilnadu@gmail.com within 3 days of CME. So with these few introduction, may I request our state president, I think sir is traveling from Pollachi to other IMA for the inauguration and various functions. If sir is there, so welcome to address sir. Otherwise, we'll proceed into the meeting. Before that, this is our academic committee of our IMA TNSP academic committee member, Dr. S. Rekha from Chennai, Dr. V. Nandagopal from Coimbatore, Dr. M. Sushila from IMA Pudhamali High Road, and N. Subramanian from Tirunelveli. Sir is the president of IMA Tirunelveli. Sir is a rheumatologist. And Dr. K. Venkatachalam from Kodambakam IMA Chennai, and Dr. N. Sudha Ramakrishnan ma'am from Trichy, Dr. M. Janasamy sir from Kumarapalli. So welcome all the members and delegates. So may I request today's moderator, Dr. Muhammad Ibrahim sir, to take over and start the first session on panel discussion. Over to Dr. Muhammad Ibrahim. You know well, Muhammad Ibrahim sir is the consultant surgical oncologist working in the ESIC hospital and Siva Hospital, Tirunelveli. Sir is the secretary of IMA Tirunelveli. Dr. Muhammad Ibrahim did MBBS in Stanley, MS from Madras Medical College, DNB General Surgery from Madras Medical College, and MRCS from Royal College of Surgeons, Edinburgh, and a doctorate of National Board in Surgical Oncology, that is super specialty oncology degree from the Regional Cancer Center from Trivandrum, and sir is underwent a fellowship program in minimal access surgery, and sir is the fellow of Association of Surgeons of India, and he is a fellowship in robotic surgery hands-on training in 2013, and member of European Society of Surgical Oncology, and member of the Indian Association of Gastrointestinal Endoscopic Surgeons of India. And with the few intro, may I request Dr. Muhammad Ibrahim to take over and start the panel discussion. Over to Ibrahim, sir.
Sir, well, prayer by Dr. Sushila, sir.
Madam, prayer already over. Madam, no issue, madam. No,
Okay,
no,
sir.
no.
Thank you.
Welcome.
Thank you. No
Thank you.
problem, sir. Thanks. Sir.
Fine.
Okay. Already over.
Ibrahim, sir. Dr. Muhammad Ibrahim, sir.
Sir, excuse me, sir. Sir, excuse me, sir.
Dr. Ibrahim, sir, is there? Ibrahim?
Yeah.
Dr. Aravind, please check. Dr. Ibrahim, sir, is there? Otherwise, I'll introduce the panelist. Ibrahim, sir, yeah, please take over and start the session, sir.
Yes, sir. Am I audible, sir?
Audible, sir. Fine, thanks, sir.
Okay, sir. Okay, sir. Sir, first of all, thanks to the office bearers of IMA TNSB and also to the academic committee, Dr. Jayaraman, sir, and all the members of the academic committee for giving us the opportunity. Since February 4th is World Cancer Prevention Day, we have considered to have a panel discussion on cancer. So we have top 3 eminent medical oncologists, surgical oncologists, and radiation oncologists from all parts of the Tamil Nadu. So for the pattern of today's program is we'll have a short description on the 3 fields: surgical, medical, and radiation oncology. So first we'll have a short presentation by Dr. N. Syed Ismail, who is a medical oncologist working in SIMS Hospital. I request Dr. Prabhuraj sir to present the slide CV of Dr. Syed Ismail sir, and then Dr. Syed Ismail sir can proceed with the presentation. So once all the 3 presentations are over, we'll have a panel discussion on important cases. Since the target audience is general practitioners and non-oncologists, we would like to keep the discussion very simple so that it will be easily understandable and with simple jargons. So now over to Dr. Syed Ismail sir. Before that, I request Dr. Prabhupada sir to share the slide of the CV of Dr. Syed Ismail sir.
Audible. Ibrahim, sir, are you audible?
Yes, sir. Yes, sir. Audible, sir.
Audible, sir.
Sir, good morning, sir. Sir, can you please add me as co-host so that I can share the slides?
Yeah, Mr. Aravind, please make Prabhupada sir as a co-host. Aravind, please note.
Okay, sir. Okay, sir. I will.
Prabhupada sir, you see the screen and make him co-host. You make all the speakers, Syed Ismail sir, Satish sir, Sendil sir, and Ibrahim, everybody to make us co-host.
Jayaraman, sir, you are a host now, sir, for today. They
No,
made
no,
you as a host. I
okay.
can.
Sir, I think only Jayaraman sir can make because he's the host, I think. So he only can make others as co-host.
Yeah. I'll do that. Madam, good morning, Dr. Jayaraman. Madam. Yes, Prabhupada sir, now you are a co-host. You can start your sharing your presentation.
Thank you, sir. Thank you.
Yes, sir. Sorry for the slight delay.
No.
I request Prabhupada sir to slide show, sir. So Dr. N. Syed Ismail, he did his MD-RT and DM followed by DNB Medical Oncology. He is a HOD and Senior Consultant of Medical Oncology, SIMS Hospital, Vadabalani, and he has several papers as publications. And his special interests are solid malignancies, hemato-oncology, pediatric oncology, and stem cell transplant. So over to Dr. Syed Ismail, sir. So he will give a brief outline of what is medical oncology. No, there will not be any presentation, just a brief outline of what is medical oncology and what is the basic outline of medical oncology. Over to Dr. Syed.
Hello, am I audible?
Yes, sir.
Yeah. First of all, I thank all the IMA members and chairman to giving this opportunity to present here. I briefly tell about what are the roles of medical oncology. In medical, previously in 1950s, only the role of chemotherapy is there. The chemotherapies they are drugs used for use in the form of IV injection form to kill the cancer cells, and it is also in the oral form. Nowadays, we have multiple agents and multiple target agents and immunotherapy. It also plays a role. The medical oncology plays a role in all types of cancer in both solid malignancies and the chemotherapeutic drugs, it is used in the form of injections and oral form, and target agents are coming now. Target agents like tyrosine kinase inhibitors, oral drugs are used for the liquid malignancies and in the sarcomas also. And immunotherapy, there are multiple immunotherapies are there. It is used for to look for the any programmed blood ligand inhibitors like PD-L1 positive cancers will be treated with immunotherapy. Not in the early stages like stage 1 to 3. Only for stage 4 stages the immunotherapy is used. The mainly used drugs are this pembrolizumab, nivolumab, atezolizumab. These are the drugs are used in the immunotherapy. The target agents like tyrosine kinase inhibitors are also used in the lung cancers and sarcomas like GIST. It plays a main roles. And in future there are some cancer vaccines are also coming. And other drugs are like monoclonal antibodies are there. The most commonly used monoclonal antibodies are trastuzumab. This is used in the cancer which are present with the HER2 positive receptors like breast cancers, and in some of the gastrointestinal cancer also those who are present with the HER2 positive receptors, trastuzumabs are used. In breast cancers, the treatment modalities are multiple target agents are there. It depends upon the depending upon this receptor status only we decide the treatment plan in the cancer patients. The other monoclonal antibodies are like bevacizumab. Bevacizumab, like it is an anti-VEGF, vascular endothelial growth factor inhibitor. It is most commonly used in the colorectal cancers and in the ovarian cancers and lung cancers. This monoclonal antibodies are used. Other monoclonal antibodies are rituximab. This rituximab is the drug which is antagonist to anti-CD20. CD20 positive lymphomas are treated with rituximab. Here, the result when compared with without rituximab, with rituximab, the results are very good and the curative rate is very high. The medical oncology now they are focused around in the immunotherapy to giving the most of the patients we are trying to bring in the adjuvant treatment modalities also. In medical oncology, all the stages are treated with chemotherapy. Either it has a curative outcome, primarily treated with only neoadjuvant chemotherapy, followed by surgery. Like like in breast cancers, where the locally advanced breast cancers present with without metastasis. Neoadjuvant chemotherapy is given and followed by this neoadjuvant chemotherapy. The rationale of giving this neoadjuvant chemotherapy is to convert the non-resectable tumor into resectable one. Once it is comes resectable, then we submit the patients to the surgeon for go for modified radical mastectomy. And the rationale of using this adjuvant chemotherapy is to address the microscopic cells present in the body, to kill that cell to prevent the recurrence. And some tumors like lymphomas, where the primary treatment modalities is the medical chemotherapy only. It gives curative attempt with plus or minus radiotherapy issues. This radiotherapy is for the consolidating or boosting the large lymph nodes. And final, the stage 4. Most of the stage 4 cancers, palliative mostly take over by the medical oncology department. Here, the aim of treatment is giving the palliation to treat to of life of the patient till the patient dies. This in stage 4, we continue the treatment till the patient dies up to any progression of the disease. Our patient is not tolerating the chemotherapy, then only we stop in the stage 4 disease. Thank you.
Sir, so a short and crisp explanation of medical oncology for general practitioners. Now I request our radiation oncologist, Dr. Satish Srinivasan from Apollo Hospitals, Madurai, to make a presentation, short presentation on radiation oncological aspects for general practitioners. I request Dr. Prabhurat sir to share the thing. Yeah, Dr. Satish Srinivasan, he is graduated in MD-RT. He did MBBS from Tanjavur Medical College and graduated in 2004 and did MD-RT from Madras Medical College. He worked as a senior resident in Jipmer, Pondicherry. He is a consultant in Rajkot Cancer Society, previously Meenakshi Hospital, Apollo Specialty Hospital, Madurai, and his special interests are head and neck cancer and breast cancer. Over to Dr. G. Satish Srinivasan for a short presentation on radiation oncology. Please, sir.
Dr. Ibrahim, sir. Am I audible?
Yes, sir. You are audible, sir. You can
Yes.
proceed.
I thank IMA for this opportunity for sharing a few words on this wonderful Sunday. So when we come to radiation oncology, generally we divide tumors into two types. One is hematological tumors, that is leukemias and lymphomas, and another is solid tumors. Solid tumors constitute around 85% of all malignancies. So whenever you want to cure a solid tumor, you need some form of local therapy. Apart from the chemotherapy that takes care of the systemic disease, some local therapy has to be given if you want to cure a solid tumor. And there are two types of local therapy available with us. One is surgery and another is radiation. So we can think of radiation as an alternative to surgery or as a supplement to surgery, depending upon the scenario. So there are areas where surgery can theoretically cure the patient, but it can leave the patient with a post-operative morbidity, something like a CA larynx patient. Surgery will cure the patient, but patient will have loss of voice post-surgery. So in such scenarios, your radiation can act as an alternative to surgery. So it replaces surgery as a local therapy. But practically in many scenarios where radiation plays a role is as an adjuvant to the surgery. So when you do surgery for a cancer patient, you have to remove not only the tumor, but also the surrounding normal tissues to achieve a clear margin. Sometimes what happens is the patient presents at a later stage, so that even a complete surgery will theoretically leave behind a microscopic disease, and that can lead to recurrence for a patient. In such scenarios, after surgery or sometimes before surgery, we integrate radiation so that it addresses the microscopic cells and make sure that the work of the surgeon is giving maximum benefit to the patient by preventing a recurrence. So this in short is what the role of radiation oncology is. Thank you, sir. Over to you.
Short presentation on radiation oncology. Now over to the main thing is surgery. So in solid tumor, surgery plays a vital role in treatment, both in curative as well as palliative. So now I request Dr. N. Sendil Kumar, surgical oncologist from Coimbatore Medical College, to do a short presentation on recent advances in surgical oncology for the sake of. For that, I would like to have a short CV. Dr. Sendil Kumar did his undergraduation from Stanley Medical College. He passed out in 2004 and did his MS from Madras Medical College, and did surgical oncology DNB from RCC Trivandrum, and he is now an assistant professor in the Department of Surgical Oncology from Coimbatore Medical College. Over to Dr. Sendil Kumar, please, sir.
Thank you for short introduction. Am I audible? Hello?
Yes, sir. Audible, sir. Yes, sir.
Yes, sir. I thank IMA for giving this opportunity. With simple words, I like to explain the principles in surgical oncology. Surgical oncology is generally an fine-tuning of general surgery. It includes biopsy and imaging initially. Biopsy, it might be a guided biopsy or an incisional biopsy. Guided biopsy can be done by any persons, but when it comes for an incisional biopsy, it should be done by a surgeon who does the final surgery, and so that the morbidity will be reduced. And imaging also, whoever does the final surgery should do the imaging and plan the imaging, CT or MRI, specific cuts in specific sequence. For example, in pancreatic CA, we need a pancreatic protocol CT with 3 phases. So we commonly come across imaging done by someone else, and therefore it's very difficult for us. And after imaging and biopsy, we sit with a teamwork with the radiation oncologists, medical oncologists, and surgeons, and we plan which treatment should be given to the patient.
Hello.
Yes. And surgery, previously when When surgical oncology field was originated, it was very radical surgery. Now more of conservative surgery has come up. For example, initially only we did a mastectomy for breast. From radical mastectomy to we went on with the modified radical. Now the conservation has come. Even with conservation, we are now doing a reconstruction with oncoplasty. And coming to margins, this is the one place where we differ from other surgeons. Negative margin must be the prime thing, and end block resection should be done. And we should respect planes, and it should be a bloodless field. And local regional staging must be must. And for node negative patients, we should address the regional nodes which are at risk, either by elective node dissection or by sentinel node dissection. If nodes are present, then the therapeutic lymph node dissection must be done. Sentinel node dissection avoid, this minimizes the morbidity of nodal dissection, and we'll be seeing in our panel discussion. Thank you.
Dr. Sendil. So it was a short and sweet presentation. So the basic idea of oncology is no more a single doctor or a single consultant to consider. It is always a comprehensive cancer care. So comprehensive cancer care includes, it's like a tumor board discussion of radiation oncology, medical oncology, as well as surgical oncology, and also palliative therapy. And also Dr. Sendil Kumar highlighted the importance of negative margins and also various diagnostic modalities like confirmation of the diagnosis and also negative margin during resection. Now we'll go to the panel discussion. So I request Dr. Prabhuraj to change the slides. Yeah. So first is a case scenario. All the consultants, Dr. Sendil Kumar, Dr. Satish Srinivasan, and Dr. Syed Ismail can unmute the mic and keep ready. So 1 month, it's a 53-year-old male patient, 1 month history of tongue soreness and pain. He has not noticed any change in voice, difficulty in swallowing, or a neck mask. And the medical history shows type 2 diabetes, controlled with oral agents and hypertension. He does not smoke, no history of tobacco or alcohol abuse. No other past medical history was identified. So over to Dr. Sendil Kumar, what will be the next step?
I like to examine the lesion, oral cavity, and look for the lesion and any sharp tooth. Since he doesn't have any habits, I like to know the etiology.
Yes. So for any case, first step is a clinical examination. So next slide, please. Next slide. Yeah. On the clinical examination, the oral cavity shows a slightly raised lesion on the right lateral tongue border, which is soft and tender to palpation, measuring 1 centimeter in diameter. There is no mass noted deep to the lesion, no palpable neck nodes, and fiber optic laryngoscopy is within normal limits. So what will be the next step, Dr. Satish Srinivasan, sir?
We have to proceed with the biopsy, sir. So we have to identify the histopathology and then plan the management accordingly.
Yes, sir. So biopsy, usually we indicate whenever there is a symptom which is not responding to the standard treatment for 2 weeks. So we don't biopsy all the tongue ulcers, but if the ulcer is chronic, present for more than 2 weeks, in spite of all the treatment modalities, then we go for a tissue sampling. So over to Dr. Sendil Kumar, sir. So what type of tissue biopsy you would like to take, and what will be the
I like to take an edge biopsy from the edge of the lesion from elevated edge.
Yes, it will be under which anesthesia, sir?
Under local. We can do it
local anesthesia. So it is always a wedge biopsy from the edge of the ulcer, which includes both the tumor as well as the normal tissue. And the biopsy shows moderately differentiated squamous cell carcinoma with a depth of invasion of at least 4 millimeters and biopsy specimen with tumor transected at the base. So what will be the next in the workup? And Dr. Sendil Kumar sir was mentioning about imaging. So do you need to have any imaging here, any CT scan or MRI, any imaging here?
This is a very small lesion with 1 centimeter over the lateral border of tongue, and there is no ankylosing, floor is free. So for this lesion, clinical examination is more than enough for palpation of nodes, but
Yes.
we can do a CT also.
Yes. So for a smaller lesion, clinical examination is the main thing. So CT scan with contrast necessary for nodal assessment alone, and MRI may be needed in case of suspected lesion which is crossing the midline or abutting the midline to give a negative margin during resection. And the risk of distant metastasis in early lesions like T1 or T2 lesion less than 2 to 4 centimeters, it is extremely low. Therefore, extensive metastatic workup is not necessary. Clinical assessment is sufficient. And PET, which has become very common in recent days, doesn't have any added advantage. And CT chest to rule out lung metastasis is considered adequate if you suspect an advanced disease. So what will be the next step, sir, after the imaging? So the diagnosis has come as moderately differentiated squamous cell carcinoma, lateral border of tongue, clinical staging T1, N0, M0.
So the plan will be to discuss the case in the tumor board and probably to take the surgical oncologist opinion regarding the feasibility of surgery and the extent of surgery to be discussed.
Yes, sir. Yes, sir. I will come to you. So first, I would like to get the surgeon's opinion.
It's a very small lesion, clinical T1, N0, M0, but depth is more than 4 mm. So we need to address the primary, that is tongue lesion with 1 centimeter margin. We should do a myeloablative excision. And since the depth is more important in oral cavity lesion, we should address the node. We should plan for an elective neck node dissection, removing 1, 2, 3, if possible 4 also. It's called a supramoid neck dissection or extended supramoid neck dissection.
Yes, sir. So carcinoma tongue is a highly vascular and highly lymphatic structure. So lymph nodal metastasis can be present. Ductal metastasis can be present even if it is a clinically N0 neck. So we have to plan for a surgery. So surgery is the first modality of treatment. So it is wide excision with of the primary tumor and addressing the regional nodes. So if the patient is not willing for surgery, what will be the treatment? Over to Dr. Satish, sir.
Ideally, there is radiation is not as good as surgery when it comes to oral cavity lesions, sir. But if the patient is not operable because of either comorbid conditions or not willingness, there is an option of considering radical external limb radiation therapy plus adding brachytherapy boost if the facilities are available, so that the chances of local occurrence are minimized to the maximum.
Yes, sir. So So there is an option of radiation treatment also in case of patient not willing for surgery. Otherwise, surgery is the prime modality of treatment in early tongue cancers. Now over to Dr. Sayyid Ismail, sir, medical oncologist. So is there any role of medical oncology in this case, sir?
Actually, for yearly lesion, clinically T1 and N0, M0, and after a post-op biopsy report, it shows only one node is involved without extranodal extension. I think there is no much role for chemotherapy either as a weekly or every 21 days once. Radiotherapy is enough, I think so. It is adequate for this lesion.
Yes, sir. So over to Dr. Satish, sir. So here it is the final pathological staging is T2, N1, M0 pathological stage. What will be the adjuvant treatment? And if radiation, where it will be given, whether it will be given to the neck or it will be given to the tongue area or to both areas, or in special circumstances, both areas, what will be the strategy, sir?
So generally, we decided on one factor to consider is the location of the primary. So if it is a well lateralized lesion, we may be able to get away with treating only the ipsilateral neck. But if the lesion is approaching the midline, it is better to address both sides neck because there can be crossover lymphatics, and level 4 metastases are known to happen without level 2 or level 3 involvement. So this particular patient, there is nodal positivity, so we will have to address because the neck dissection will usually be a supraomohyoid dissection. The lower neck will not be addressed generally, I presume. So we will cover up to the level 4 with 54 gray. This is a well lateralized lesion, so I will not bother about treating the contralateral entire neck. So ipsilateral neck up to 54 gray, and the tumor bed probably up to 60 gray. So there is a minimum dose that is required for a primary tumor bed.
Okay, sir. Thank you. So Dr. Satish, sir, and Dr. Sendil Kumar, sir, were mentioning something about. Yes, sir. Yes, sir. Please, sir.
to Dr. Satish Srinivas. The role
Yes,
of
sir.
interstitial brachytherapy in this case.
Yes, sir. If you are, the margins are adequate, sir. So there is no role for post-operative brachytherapy. But if you are considering radical treatment, yes, there is a role for brachytherapy.
In brachytherapy, how much dose you will give?
Sir, it will be a boost after 60 gray. Probably around 20 gray equivalent boost to the tumor bed, sir.
Okay.
Okay, sir. Thank you. And Dr. Satish sir and Dr. Sendil Kumar sir were mentioning about supraomohyoid neck dissection. It is nothing but removal of the level 1, 1A, 1B, 2A, 2B, and 3 nodes. So that is supraomohyoid neck dissection. So the take-home message is tongue is a very vascular structure. Early tongue cancers, surgery is the main modality of treatment. Advanced cancer, we may need adjuvant treatment or primary chemo RT. And also the location of the tumor and biopsy, it's very, very mandatory, and negative margins during resection is also very, very important. And addressing the nodes is also very important. Yes, sir.
What is the etiology for this patient? He comes with bad habits, and why there is a lesion tongue?
It can be a HPV infection, sir. HPV may be the cause.
The anterior to third tongue, mostly this HPV in the posterior one tongue is most common. Any the short tooth is there in this patient? Hello? Hello?
Tract. Am I audible, sir? Prabhat sir, am I audible?
Audible.
Yes, sir. Respiratory tract malignancy.
Yes, sir. Yes, sir.
So next slide, sir, please. So 50-year-old male patient, he is having a chronic cough, hemoptysis, and dyspnea. So chest X-ray was taken, which shows consolidation type of lesion in right upper lobe with mild to moderate pleural effusion. So what will be the next step? Satish, sir. Satish Srinivasan, sir.
So in CA lung, the idea of evaluation is to identify the most distal disease. The patient has a brain mets or a liver mets, our management changes. This patient has a pleural effusion. So we will actually try to see if the effusion is because of the malignancy. If that is the case, the management itself changes. So the first step I would like this to do a pleural tapping and send it for analysis.
Okay, sir. How often you will get a positive diagnosis in pleural tapping, even if it is a positive disease? How often you will get it, sir? So how will you send the sample? Will it just a cytology or a cell block, sir?
Yes, sir. We request for a cell block after centrifuging so that the yield is higher. Simple cytology may not be sufficient.
Yes, sir. That's a very important. We need to send at least 20 ml of the pleural fluid for making the cell blocks. And while during the centrifugation, the chances of getting the malignancy cells is higher. But even if we get a negative diagnosis in cytology as well as cell block, we need to reconsider our thing and we have to look for other things. So what will be the role of bronchoscopy and what will be the FNAC or biopsy? Dr. Sendil Kumar, sir.
The bronchoscopy, the lesion is more towards the bronchus. There is centrally placed lesions we can assess with the bronchoscopy. And for staging, EBUS can be done. For early disease, for active disease, we can do an EBUS. This is the two roles for bronchoscopy.
So the location of the tumor is very important to decide on what diagnostic modality we are going to use. So what are the metastatic workup we are going to do in this case, sir? Doctor, say this point, sir.
Actually, first of all, I want to, if the patient comes like this, I will do the CT chest to locate the lesion with to go for bronchoscopy. Suppose if the lesion is in the periphery, I will ask the patient to go with CT guided biopsy. Once the biopsy is confirmed with malignancy, and we want to know the subtype of this malignancy, followed by staging workup. Staging workup, I prefer to go with whole body PET CT scan. And depending upon the biopsy report, I will ask the further markers to treat this cancer, lung cancer patient.
So PET scan is one of the metastatic workup modality in carcinoma lung. And is there any role of RT in SVC obstruction, sir? Any role of RT, direct RT without any going into other metastatic workup, Dr. Satish, sir?
Yes, sir. Like usually what we recommend, the traditional teaching is SVC obstruction, we can go for RT, but nowadays if the facilities are available, stenting can be considered. Because it is only extensive compression and stenting will actually relieve the SVCO. But if that is not available, we can consider a short course of radiation to improve the patient symptoms and go on and address the primary tumor in the appropriate way possible.
So can we give RT without histological diagnosis in this case?
No,
Sir?
we generally do not advise that, sir. If it is a small cell carcinoma, the tumor can completely disappear after we give RT and we will be in a soup. If it is a lymphoma also, there can be SVCO. So we don't want that.
So this has to be. So this has to be kept in mind, and there is no role of RT if there is, we don't have a tissue diagnosis. Dr. Prabharaj, sir, next slide, please. So the carcinoma lung, all the PET scan and biopsy has come as adenocarcinoma stage 4. So do we need any IHC markers? Dr. Sayyid Ismail, sir,
Yeah.
IHC markers for this CA lung?
Yeah,
If yes, what are the markers you routinely see, sir? What is the routine panel of markers you see?
in adenocarcinoma, we must ask the patient to go for these ISC markers. The most commonly ISC markers we ask EGFR mutation status and KRAS and EMF4. And we will ask the PDL1 status in this patient. Suppose PDL1 is more than 1%, we will ask the patient to have this immunotherapy. The immunotherapy plays a main role in this adenocarcinoma lung in stage 4. So ISC is mandatory in CA lung adenocarcinoma stage 4 cases.
So take home message is IHC is mandatory in adenocarcinoma lung because we have got a lot of panel of drugs, targeted drugs, which if some of the markers are positive and it will have very good prognosis. So what will be the role of surgery in lung cancer? Leave alone this stage 4, any lung cancer, and specific to stage 4, what is the role? Dr. Sendil Kumar, sir.
The role of surgery comes only in early stage lung cancer, not for T1, T2, and T3, some T3 lesions with N1 disease, we can do surgery. Not for stage 4 disease.
So even though carcinoma lung is very much predominant among males in India, the role of surgery is minimal because the presentation is usually in stage 3 or stage 4. So what will be the role of RT in lung cancer, sir? Dr. Satyaj, sir.
So any non-metastatic cancer, there is a definite role for radiation because most of the patient, any N2 disease, we are not supposed to do surgery. So in all those subsets, we are going to use radiation for either as a radical therapy. If it is a superior cervical stimulus, we can give it as a preoperative radiation. And it has a role in palliative setting also, either for bone mets or palliative mets, I mean brain mets.
Okay, sir. And chemotherapy and targeted therapy already Dr. Sayyid Ismail sir talked. I request Dr. Sendil Kumar sir to mention about the role of ICD and fluorosis. If the patient is having continuous tapping, frequent tapping, so what is the role of ICD and fluorosis and how do you do that, sir?
If the patient has a frequent tapping, we can insert an ICD tube. And if the ICD comes below 100, we can do a fluorosis with a bleomycin or a TARC. So
Yes, sir. Thank you. Already we have discussed about the role of PET-CT. So next slide, sir, please. Prabharaj, sir, next slide, please. So we'll go to another case. We have got 12 minutes more. So 44-year-old premenopausal lady presents with lump in the left breast for 4 months duration. On clinical examination, it is 3 into 2 centimeter lump in the upper outer quadrant of left breast, no axillary nodes clinically. Right breast and axilla normal, no supraclavicular nodes. How will you investigate this patient? Dr. Sendil Kumar, sir.
It's a premenopausal lady with 45 years age. I like to do a mammogram with ultrasound. With the report, I will plan my thing with an FNAC.
So for any breast examination, it is always a triple assessment, clinical examination followed by an imaging. So since it is a perimenopausal lady, about 35 years, mammogram can be done with a sonomammogram. And next thing is a pathological examination. So what type of pathological examination do you like to do? Whether you want to do an FNAC or a true cut biopsy?
It's a BRAS 3C lesion. FNAC is enough.
So BRATs, many persons may not be aware of it. So it's a radiological staging of breast lesions. So if it is less than 3, chances of benign is more. If it is 4 and 5, it is chance of malignancy is more. So less than 3, we can do an FNAC and keep on follow up if the diagnosis comes as benign. Now the FNAC has come as proliferative breast disease. What will be the next step, sir? Sendil Kumar, sir.
So proliferative breast disease. Simple excision biopsy is more than adequate for this patient.
Is there any role of just following it up, whether we need to definitely remove the tumor or we can just follow? What is your opinion? There is a palpable lump and also FNAC is proliferative disease. So can we just leave it or you want to exercise definitely?
Exercise, if it comes as a proliferative breast disease with ATPR, then definitely we should exercise.
Yes, sir. Yes, sir. So that is very important. So even if the FNAC comes as a benign or a doubtful thing, the ultimate thing is we have to excise it. So the true cut here we have done a true cut biopsy also because the lesion was palpable and it has come as atypical hyperplasia. What will you do? FNAC is proliferative disease, breast disease. True cut has come as atypical hyperplasia. So there is some ATPR.
Definitely, I will go ahead with surgery.
So it's a wide excision with negative margins. So next slide, sir. Next slide. So atypical hyperplasia is considered as a high risk lesion because of increased risk of developing future breast cancer. It is not considered pre-malignant because lesions do not necessarily develop at the site of atypical hyperplasia. This is very important and the treatment is excision. Next slide. So excision shows atypical ductal hyperplasia, but margins we have got positive. So do you want to do any re-excision?
It's not needed since it's not a malignancy. We need not do a re-excision. We can just follow.
Yes. So we need not do a re-excision of the positive margin. Next slide. Next slide, sir. Suppose if the core biopsy comes as LCIS. So what is LCIS and how you will proceed? Dr. Sendil, sir.
Lobular carcinoma in situ, if it comes as a core biopsy, there are some evidence to show that we can do an excision biopsy. It might have an invasive component in the excision biopsy test. So,
is LCIS and DCIS are same, sir? Whether we have to excise both or DCIS is more dangerous? Which is more dangerous?
DCIS, definitely I should do surgery. For LCS, we can follow also. For ductal carcinoma in situ, definitely we should go for surgery.
Yes, yes, sir. Next slide, sir. Next slide. Next slide. Next slide. So suppose if the core biopsy comes as DCIS, ductal carcinoma in situ instead of LCIS, what will be the procedure? How will you proceed?
If it comes as a ductal carcinoma in situ, I will mammogram features. If mammogram shows a single lesion confined to one part of the breast, I can plan for a wide excision. Since it's a palpable disease, I should address the node also. If facilities are available, I can do a sentinel node. Since palpable DCS have an invasive component in the final pathology report.
So whether DCIS, we have to do definitely we have to do a excision with negative margins. Any role of RT, sir? Dr. Satish, sir, any role of RT in DCIS?
Yes, sir. Radiation definitely reduces the chances of recurrence in the ipsilateral breast. So post excision, radiation has a role.
Yes, sir. So definitely there is a role of RT in DCIS also. Next slide, sir. So what are the indications for mastectomy in case of DCIS? Indication of mastectomy.
If it is a
Dr. Sendil, sir.
If it is involving multicentric disease in all quadrants of the breast, then if even after removing wide excision, the margin comes positive, persistent positive margin, then we should do. And if the patient has a hereditary breast cancer family history like BRCA1 BRCA2 mutation, then we should go ahead with the mastectomy. Otherwise, we can do a wide excision.
Next slide, sir. Next slide. Next slide. We'll skip this. Yeah. Next slide. So the previous slide, sir. So is there any role of systemic treatment in case of DCIS, sir? Dr. Sayyid Ismail, sir. Any role of systemic therapy?
For DCIS, there is no role for systemic therapy. Only hormonal therapy is a role. This hormonal therapy is given for ER positive DCIS who have not undergone bilateral mastectomy patients. Hormonal therapy, either tamoxifen or anastrozole, is given for 5 years, only to prevent the ipsilateral recurrence and contralateral recurrence also.
Okay, sir. Okay, sir. Fine, sir. Thank you. So Next slide, we'll have a next case on gynec oncology. We have got less time, 8 minutes only. So gynec oncology, already a gynecologist, they're waiting for her presentation. So it's a 43-year-old female patient, perimenopausal, complaints of bleeding per vaginum and white discharge per vaginum for 5 months duration. How do you evaluate? Dr. Sayed Ismail.
First, clinical examination is very important, and patient having, we have to look for any post-coital bleeding. Suppose if post-coital bleeding is there, we have to think of this cancer cervix. And perivaginal examination is mandatory to look for that any ulcer-proliferative growth is seen in the cervix. Suppose if growth is there, means you have to look, ask the patient to go for this punch biopsy to confirm the lesion, whether it's a malignant or some other lesion. Once biopsy is confirmed, then you have to look for the staging workup, followed by treatment according to the stage.
Yes, sir. So any role of imaging before taking a biopsy, Dr. Sendil Kumar, sir?
We can do an biopsy and then take imaging. It will not alter for CSF. Ideally, when the MRI pelvis with abdominal screening is a must.
So if it is a bleeding per vaginum, it can be a vaginal growth, it can be a cervical growth, or it can be an endometrial growth. So clinical examination, if you see a growth, you can take a biopsy. If the growth is not visible, it is better to go with an imaging, either a CT or MRI preferably, and then we go for a targeted biopsy. Next slide. Next slide, sir. Yeah. So the final diagnosis after biopsy and imaging, it has come as moderately differentiated squamous cell carcinoma, cervix stage 2B. So this cervical staging, how different it is from other staging, sir? Dr. Satish Srinivasan, sir.
Yeah, so unlike other gynecological malignancies where imaging plays an important role, in cervix, because of the demography, we prefer the clinical staging. And
Yes,
this
sir.
is the, yes.
So cervical staging, the FIGO staging is basically a clinical staging rather than a diagnostic staging. And MRI can be used to assess the extent of invasion, local invasion, and also to assess the nodal status. How to proceed in this case, sir? Dr. Satish, sir?
Since it's a 2B lesion, usually we consider the patient for radical radiation with the concurrent chemotherapy, sir. So we assess the patient's RFT, LFT, and then discuss with the medical analyst and plan for a radical course of external beam radiation, 50 gray, 5 weeks, followed by intracavity brachytherapy.
How many intracavitary application or high HDR treatment, how many times you have to give, sir?
Usually we plan for 3 sittings, 21 gray, 3 fractions.
So after the EBRT, when you will start the HDR treatment? How many weeks after the EBRT?
We can integrate with the brachytherapy if the patient is tolerating in between also, but generally we wait for a week for the external beam reaction to settle down and then we plan the brachytherapy.
Yes, sir. So in many of the institutions, this brachytherapy may not be there. So some of the patients skip the brachytherapy. Is it advisable to skip, or it is mandatory to take a HDR?
We cannot give CSFX without brachytherapy, sir. External beam alone is not sufficient. The patient literally has to undergo.
So the take-home message for all the audiences is, if it is a locally advanced carcinoma cervix, primary chemo radiation is the treatment, and it is a place where HDR or brachytherapy plays a very important vital role. So always a external beam RT to the pelvis area followed by a HDR has to be given. Next slide, sir. We'll have one more case. We have got 4 more minutes. So 40-year-old male patient, recurrent abdominal pain, predominantly epigastric, treated with a proton pump inhibitors and H2 blockers, but pain progressed. Now with vomiting, non-bilious, 1 to 2 hours postprandial. Next slide. USG investigation has been done. It's dilated stomach with thickened pylorus, CT pylorus with GOO, gastric outlet obstruction. Perigastric nodes are present. Upper G endoscopy shows pylorus growth, dilated stomach, biopsy taken. Next slide, sir. I'm just rushing because we have got less time. So histopathological examination comes as poorly differentiated adenocarcinoma. Further line of management, Dr. Sendil Kumar, sir.
This has obstruction, gastric obstruction. I like to go with the surgery first. I will like to do a diagnostic lab, see for extent of the disease, and if it is operable, I will proceed with subtotal gastrectomy with D2 rectal dissection, followed by medical.
Okay. Suppose if the patient is having no gastric outlet obstruction and the tumor is locally advanced with the surrounding nodes, perigastric nodes are there like this. So will you consider any other alternative treatment other than primary surgery?
Primary surgery, if a patient doesn't have a gastric obstruction, definitely I will go with the neoadjuvant chemotherapy. 3 cycles, reassess with and then proceed.
Okay, so Dr. Said Ismail sir, what is the role of neoadjuvant chemotherapy in stomach? Because we always see in our clinical practice, whenever there is a carcinoma stomach, immediate surgery is being done. So, but nowadays we see a lot of good improvement and good prognosis and also good prognostication if we use a neoadjuvant chemotherapy. What is the role, sir, in carcinoma stomach?
Locally advanced stomach cancers, or we can consider it is the presence of regional lymph nodes in the imaging wise. You have to go with neoadjuvant chemotherapy. It will increase the disease-free and overall survival also of the patient. So we will go with triple agent chemotherapy, either epirubicin, platinum plus 5-FU, or TCF regime, docetaxel, cisplatin, 5-FU. 3 cycles of chemotherapy, assess the response. If it is a good response is there, means then we will submit the patient for radical surgery, followed by adjuvant chemotherapy or concomitant chemo RT, depending upon the post-op biopsy report.
Okay, sir. Thank you. So if the thing is operable, so the final we have done a surgery because it's a GOO. So final HP report has come as a negative margins and poorly differentiated adenocarcinoma. So what will be the adjuvant treatment in this case, sir? Chemotherapy or radiotherapy? Dr. Said Ismail sir, first please tell about chemotherapy.
Adjuvant chemotherapy, I will go with the double agent like Capax regime is enough, I think so. Here already radical surgery is given to prevent the local recurrence. Capax regime is enough. Every 21 days once we will give up to 6 to 8 cycles we planned here.
Any role of radiotherapy, sir, Dr. Satish, sir?
Usually we prefer radiation. We add radiation if there are margin positivity, R1, R2 resection, or if the nodal resection is less than D2, probably there is a role, sir. Otherwise, we can go ahead with only chemo.
Thank you, sir. So now the time is 11:59. If the chairman, Dr. Jayaraman, sir, permits, we'll have one more case. Otherwise, we'll close it, sir. Dr. Jayaraman, sir.
Please proceed with another case, sir. Please proceed, sir.
One more
Yes,
case, sir.
thank you.
Thanks, sir. Thanks for the opportunity. So history is 52-year-old male patient. History of bleeding PR for past 2 years, and history of hemorrhoid surgery and native treatment for the same has been done. Patient presents with the features of intestinal obstruction. History of vomiting is present, constipation is present, and abdominal distension for past 4 days. He comes to the hospital. So we do the following investigations: abdomen X-ray, multiple air fluid levels are there. USG shows dilated bowel loops with a rectal growth. CT shows a locally advanced rectal growth with large bowel obstruction. Perirectal nodes are present. No ascites, no liver metastasis. How you will proceed, sir? Dr. Sendil Kumar, sir.
Since CT shows rectal growth with perirectal nodes and patient has acute intestinal obstruction, definitely he needs it's a locally advanced rectal cancer with intestinal obstruction, acute intestinal obstruction. But I need to decompress the intestine. If stenting is possible, I can stent. Otherwise, I go for a temporary diversion colostomy, preferably transverse colostomy. And then I will give a neoadjuvant chemo RT for the rectal lesion, then plan for reassess, then plan for surgery.
So do we need a colonoscopy preoperatively?
Yes, definitely we need a colonoscopy and biopsy.
Okay, so the surgery is palliation, palliate the symptoms, and then we go for a neoadjuvant chemo RT. So what is the neoadjuvant chemo RT protocol followed, sir? Dr. Sendil, Dr. Satish, sir, please. Satish, sir.
So usually we plan radiation like we include the primary mesorectum under the internal iliac nodes up to 45 gray and boost to the primary site for up to 50.4 gray. It will be over in 5 to 6 weeks. Plus we plan with the concurrent chemo capecitabine, usually with the medical oncologist opinion.
So the main idea of neoadjuvant chemo RT is downstaging the disease, and also another advantage is we can do a sphincter salvage. So sphincter can be salvaged. A patient who will need an abdominoperineal resection with a permanent colostomy can be made as an low anterior resection with a continent ENS. So that is the advantage of neoadjuvant chemo RT. So how long you will give the neoadjuvant chemo RT, sir? How long duration of?
Usually around 5 to 6 weeks, sir.
5 to 6 weeks. Now over to Sendil Kumar, sir. So when you would like to operate the patient immediately after radiation or after some time, and when you want to reassess, you want to do a repeat scan and assess how much it is downstaged, anything like that, sir?
This patient we will reassess at 6 weeks with the MRI pelvis with abdomen screening, and the 6 to 8 weeks we will plan for a surgery for this patient.
Yes, sir. So the surgery has to be delayed because there will be a lot of post-RT edema and changes in the area. So we have to wait for 6 to even up to 8 weeks also. And if the lesion is a little bit higher, your CT abdomen is sufficient. The lesion is very low. There may be some systemic metastasis also. So the CT test also must be done to rule out lung metastasis. So now the neoadjuvant chemo RT has been done, and after 6 weeks the surgery has been done. And the surgery has come as it's a moderately differentiated adenocarcinoma. All margins negative, proximal margin, distal margin, and circumferential margin. All 3 margins negative. Nodes 2 to 3 nodes positive out of 15 nodes. So what will be the role of adjuvant chemotherapy in this case, sir? Dr. Syed Ismail, sir.
Actually, for this case, we have the insertion protocol. Here, after the completion of this concurrent chemo RT, we will give the gap of 6 to 8 weeks. In this time duration, we give 2 more cycles of capox regimens every 21 days once. After completion of these 2 cycles chemo, we submit the patient for the radical surgery. After this radical surgery and patient having this node means, then we plan for another 6 more cycles of capox regime to complete the treatment. After that, we will keep the patient under follow-up.
So this capox regimen, that is capecitabine with oxaliplatin, can be given even pre-operatively also.
Pre-operatively, after completion of this concurrent chemo RT, the gap is given 6 to 8 weeks. They have given
6 to 8 weeks, like a sandwich, a sandwich chemotherapy we can give. So that's an added advantage.
Added advantage.
Yes, sir. Yes, sir.
And there is another entity is also there here. It is also total neoadjuvant therapy is also now we are practicing. We are giving full course of treatment, and also after completion of all the treatment, we will assess the response. If complete response is there, means we will avoid the radical surgery also in this case. Suppose any residual lesion is there after completion of planned therapy, then we will submit the patient for the radical surgery.
Okay, sir. So thank you, sir. All the 3 consultants. It was a wonderful discussion. The idea of presenting all these cases is any treatment of malignancy is not a single consultant treatment. It is a multimodality treatment based on tumor board discussion. It's a comprehensive cancer care. So if you take this carcinoma rectum, you need the role of radiation oncologist, medical oncologist, and surgical oncologist. So it's always a comprehensive cancer care which gives a perfect cure to the patient and also increases the longevity and increases the prognosis of the tumor. We tell about a lot of prognosis, like prognosis because of the tumor factors and other things, but there is something called prognosis because of the treatment also. The treatment factors play a vital role in the outcome, and many of the time the patient may miss some of the treatment, like an adjuvant treatment he or she may miss. So that has to be educated to the patient so that the patient completes the treatment and he or she is on complete follow-up, so that we can have a complete cure as well as a complete follow-up of the patient. So the idea in this thing is closing the care gap. So closing the care gap is the motto of this year's World Cancer Day. So we are closing the care gap by bringing all the consultants here, and thanks to the academic committee headed by the chairman, Dr. Jayaraman sir, and also the IMA TNSB office bearers for giving us an opportunity. We have nearly 8 to 9 cases. Dr. Prabhurat sir, who is a finance secretary of IMA Tirunelveli, who himself is a radiation oncologist, has typed a lot of other case scenarios, but due to less time, we are not unable to discuss. In future, we may have a further discussion on these things, and I hope the panel discussion was useful to the audience. And instead of having a monotonous lecture, we thought we can have a lecture like this. And any doubts, the audience can put it in the chat box. If possible, we'll reply or after the next topic. Over to Dr. Jayaraman sir. Thank you, sir.
Thank you, Dr. Ibrahim sir, for this wonderful moderation with wonderful panelists like medical oncologists, surgical oncologists, and radiation oncologists. So very beautifully explained in our a nice way about the all updates of cancer diagnosis and management. So with a lot of advancements, nowadays cancer is completely curable if you pick up early. That's why these kind of CME program for all our members. So early diagnosis is very, very important. As a pulmonologist point of view, I am the lung specialist. In my area, we see a lot of lung cancer. So initially, lung cancer diagnosis is very difficult because in our country, the tuberculosis, the lung TB symptoms and the cancer symptoms are more or less same. Cough, hemoptysis, weight loss, everything is same. So we need to have a tissue diagnosis. For that, nowadays in our center in Chennai, We have EBUS bronchoscopy, endobronchial ultrasound bronchoscopy. We can reach the lesion wherever, whether it's a mediastinal, central, peripheral, endobronchial, or extrinsic, outside the wall, endobronchial wall or tracheal wall. We use the endobronchial ultrasound bronchoscopy. We can reach all the areas. Previously, we rely on CT guided needle biopsy for the peripheral lung lesions. Nowadays, with the advancements of the bronchoscope, advanced bronchoscope like EBUS, endobronchial ultrasound or endoscopic ultrasound methods, we can easily diagnose wherever the lesion, whether it's endoluminal or extraluminal, extrinsic, we can reach. And the tissue diagnosis with the molecular diagnosis like immunohistochemistry are very important. For the staging purposes, we do PET CT scan, whole body PET to assess the staging, whether the TNM stage 1, 2, 3, 4, small cell or non-small cell. For the pleural cancers, pleural malignancy, lung lesion with the metastatic to pleural cancers, sometimes very difficult. So we have a thoracoscopy, medical thoracoscopy and the local anesthesia with IV sedation. We can take the parietal pleural biopsy to clinch a diagnosis, whether it's the primary pleural cancers or it's the metastatic cancers. So then we have a tumor board meeting with our oncology, all the panels of medical, surgical, and radiation oncologists. So we'll tell the patient such a way that we do the surgery, chemotherapy, radiotherapy. Now we have a lot of advancement in chemotherapy. So targeted therapy and biological therapy, a lot of advancements nowadays. So cancer, no worry, no fear nowadays. So we have to teach give a lot of awareness program, this type of awareness. So I thank Muhammad Ibrahim sir for this wonderful moderations with the expert panelists. And I like that Sendil sir, that Ismail sir, and Satish sir. So thank you very much. So any questions, please, I request all the delegates, kindly post your questions in the chat box. So we'll have a discussion at the end of the session. Now I request Dr. Sudha Ramakrishnan ma'am to have a second talk. I request Sudha ma'am, please introduce the topic and discussion, and we will proceed to the next topic, ma'am. Sudha ma'am. Yeah.
Yes, sir. Good afternoon, everyone. After a very informative session on gynecology, on oncology, we move on to the second today's CME, that is gynec problems. So adolescence is a period of enormous physical and psychological also for girls. While majority of the young girls cruise through this period very smoothly, there is a considerable number of young girls who face problems. So, and the adolescent gynae and problems contribute to a major of the global burden of sexual ill health, often goes unnoticed. So to enlighten us on this topic, we have a very eminent obstetrician and gynecologist, Dr. Upala Manikavasagam. Very happy to have you here, madam. So madam has a MD and DNB degree. So she's also a gold medalist in DNB. She practices at Lakshmi Madhavan Hospital, has numerous publications to her credit, and madam is a very busy practitioner. So when I inquired about madam, I was told that she delivers more babies than the government hospital. So such is the quantum of work madam does in forms of safe motherhood. So very happy to have you here, madam, and over to you, madam, to enlighten us further on this topic. Madhumala, madam, over to you.
Good morning, everyone. Yeah. Thank you, Dr. Sudha. It's such an embarrassment of my introduction. It is not like that. We are humble and we have to deliver whatever has been given to us by God. So after listening to this exhaustive topic on adult cancers, I was just thinking, why are we talking about adolescent reproductive and sexual health? And of course, it is quite relevant because we are celebrating the adolescent month. The March month is celebrated as adolescent month. And the last week of March, around 26th of March, will be the adolescent week. And the theme of this International Association of Adolescent Health of this year, 2023, would be building a healthier and an inclusive future for our adolescents. So our adolescents are our future adults, and it's no surprise we have to be very well aware of our reproductive and sexual health of our adolescents. Can I screen share now?
Yes, madam.
Can you stop screen sharing so that I can share it?
Jairam, help with that because I'm
yes,
not.
ma'am. Yeah, yes, please. Arvind? Mr.
Yes, sir.
Arvind,
Allowed now, sir.
make Madhubala ma'am as a co-host, then only madam can share the screen.
Done, sir. Done.
Done, sir. Madam, you can please share the screen. You can share the screen, madam, please.
Oh, sure.
You've been made co-host, madam, so I think you should be able to share the screen.
1 second.
Arvind, can you help the Madhubala ma'am how to share the screen at all? Arvind?
Yes, sir. I will do.
Yeah. Till then, I request Prabhuresh sir and the Ibrahim sir, you can have any questions in the chat box, you can ask our panelist, our oncologist team. Ibrahim sir, see the question chat box, any query, any no?
Madam, in the center you have a green icon share screen, madam.
Yeah, that is there, but it is not opening this presentation. It's coming as fastest version of
Madam,
one.
Madam, you can email the
எனக்கு email பண்றீங்களா madam?
Sure. There is an email. Okay, 1 second.
Chat box email one type on sir, Prabhuresh sir or Arvind, you can type your email ID. Madam will send now, so we can have the presentation. Till then, I request Ibrahim sir to see any chat box questions we can discuss about the medical oncology or surgical oncology and radiation oncology topically. Madam, please note Dr. Prabhuraj@gmail.com.
Now, can you see?
இல்ல ma'am. No ma'am. No ma'am.
No, ma'am.
Okay. So, doctor.
Yeah.
DR. PRABHU.
Okay.
RAJ@gmail.com. DR Prabhuraj@gmail.com.
Dr. Prabhuraj@gmail.com. You can send the presentation to Dr. Prabhuraj@gmail.com. Sir will play from.
Yeah, I have sent.
1 second. 1 second.
Did you receive the presentation, sir? Prabhuresh sir?
One second, sir. I'm just opening.
Yeah. Take it one. Dr. Ibrahim sir or Dr. Syed Ismail sir, please see the chat box. Any questions related with oncology?
Ibrahim sir has left, sir.
No problem. Yeah, Syed sir, Syed Ismail sir. Syed sir, Sendil sir, and Satish sir, you can see the chat box. Any questions related to your department?
So far, no questions, sir.
I will check. I request all the members, those who are logging to now, so please mention your name, email ID, mobile number, and your TNMC registration number This is for the credit point purpose from TNMC. So once you enter after the meeting, so within 3 days of time, you can send the ₹100 to the Indian Medical Association AMS account with the IFS code, everything, and take a screenshot and send to IMA@tamilnadu@gmail.com for the TNMC credit points, 0.5 marks for each and every program. This is a 2 hours program.
கிடைக்கலையா MBM. Okay.
Arvind, please put up the details of our TNMC credit points.
Yes, sir, I will do, sir. I will do, sir.
The type பண்ணி கொஞ்சம் place பண்ணு post பண்ணுங்க.
Okay, sir.
And the accounts for the Indian Medical AMS and the account ₹100 to pay in whom, no, that you will type and post it.
சொல்லுங்க பிரபு. Hello.
I request all the delegates, please note there is account detail here in the chat box. The display is coming now, and please note the number. After the meeting, you can pay online ₹100 to the Indian Medical Association AMS. That's account number. IFS code is there. So please do it for the TNMC credit points from TNMC, our credit point purpose. CME credit points. Thank you. Syed Ismail sir, there is a question to you regarding the latest treatment modalities for lung cancer. Patient is operable, but patient does not want surgery. Without surgery, it's a stage 2, stage 2, without surgery.
Sir, I am not hearing your question properly, sir.
Bye.
Some persons are interrupting. Hello?
Ismail sir.
Tell me, sir.
This is the case scenario. Stage 2, non-small cell cancer. Patient does not want surgery. Patient does not want surgery.
Okay,
so,
sir.
What is the role of chemoradiation in a case of a operable tumor? Patient is not willing to undergo the surgery.
Here, the aim of treatment in non-small cell lung cancer in stage 2 is curative attempt. If patient is not willing for surgery, then we plan for radical concurrent chemo-RT. Radical concurrent chemo-RT followed by adjuvant chemotherapy. Here, the chemotherapy is double agent. We will plan cisplatin and etoposide concurrently with radiation. The radiation is planned 50 to 60 gray and 50 gray to the tumor bed and followed by boost 10 gray. It is completed in 5 to 6 weeks. During these 6 weeks, we complete 2 cycles of chemotherapy, cisplatin and etoposide every 21 days once. After completion of radiation, another 2 more cycles of chemotherapy we plan. After the completion of radiation, at the end of 6 weeks, we will ask the patient to go for the scanning, imaging, to look for any residual lesions are there or not. Suppose if there is complete resolution, we keep the patient under follow-up. If any residual lesion is there, then we plan for another 2 more cycles of chemotherapy.
Thank you, sir. So what are the cancers we can prevent by taking vaccination? Vaccine preventable cancers.
Actually, vaccine preventable cancer are 2 cancers are there, sir. One is human papilloma virus, HPV virus to prevent the CS cervix. Another one is hepatocellular carcinoma and hepatitis B virus. We can prevent these 2 cancer can prevent with the vaccination, sir.
100%. Thank you, sir. Because vaccination role is very important. This vaccine nowadays comes under the adult vaccination, the cancer cervix vaccine as well as the liver cancer. Hepatocellular cancer vaccines are very important, comes in adult vaccination. This is all vaccine preventable cancers. So very important take the messages from your side. Thank you, Syed Ismail, sir.
Thank you, sir. Thank you.
Sir, in your experience, which cancers in India are Tamilnadu? Number 1, number 2 in male and female, sir.
Yes, sir. In females, the CA breast cancer is very common, sir. Previously, the CS cervix is very common due to this infectious human papilloma virus. Now, breast cancer is overtaking the causes for this breast cancer is we are adopting the lifestyle of Western countries, sir. We are start closing our family size. We are having 1 or 2 kids and they are not giving the breastfeeding for adequately up to 2 years. And due to this long exposure of estrogen exposing to the breast tissue will have the breast cancer. In females, the CA breast is the most common. Second one is the CS cervix. Third one is the oral cavity cancer due to tobacco chewers. And fourth is lung cancer and colorectal cancers are the cancers common in the females. In males, stomach cancer, lung cancer, head and neck cancer, prostate cancer are more common, sir.
Thank you, sir. Thank you. Is there any screening tools for lung cancer detection, sir? Early lung cancer diagnosis, any screening tool?
Yes, sir. For lung cancer, we will divide the population into 2 ways, sir. We are look for the high-risk individuals and non-high-risk individuals. High-risk individuals means those who are smokers and they have tobacco smoking year, pack year is more than 15 years. We consider them as a high-risk patient. For all these patients, we will go with ultra low voltage CT scan. Without contrast, we have to screen these people, sir. And those who are working in the mines, like mines like Nilgiris, they are using in the mines, gold mines. Those people also we consider as a high risk. For those people also we screen the lungs with low voltage CT scan.
Thank you, sir. Thank you, sir.
Thank
so high risk group of people, we suspect lung cancer. So low dose CT scan is one of the standard tool for screening lung cancer. Thank you.
For high risk individuals.
High risk individuals. Thank you.
For in India, sir, for all cancer, only 40% of the cancers are curable, sir. The remaining 60% are coming only under the palliative. The reason why it is like that means here that our individuals are, our patients are not willing to go for screening, sir. For all women crossing 45 years, we are advised to go for mammogram, but they are not voluntarily coming. But in the Western countries, the scenario is vice versa. They are giving the curity up to 70% and the remaining 30 to 40% only palliative. The reason means the patients are willingly, voluntarily, they will go for screening. In India, the screening is not making the very much difference and effect in the Indian population, sir. This is the reason why we are giving only 40% as the curative attempt, not for more than 60%.
Thank you, sir. Thank you, sir.
If we detect yearly, if we detect cancers yearly in the stage 1, stage 2, we will give 100%, more than 90% guarantee for curative attempts, sir.
Thank you, sir. Thank you.
One factor I would like to add is, can I
Please,
add one point?
Satish, sir, please, sir, please.
Yes, sir. So like as Ismail sir was saying, the detection rate is one factor. In those patients who are actually having symptoms and they are suspecting cancer, what they do is, if we go to the hospital, they are afraid that we will diagnose it as a cancer. So they don't want a diagnosis of cancer. So after knowing the symptoms, they have a fear of the treatment. So they delay 2 to 3 months just after knowing the symptoms. So what happens is in this 2 to 3 months, stage 2 cancer can easily become stage 3. So what is the cure rate of around 80% will become 60%. So another important factor we have to make sure for the patients is that the treatment is not difficult. That also they should be aware. Then only they will be willing to come for the treatment after they suspect a cancer.
100%, 100%. I fully agree, Satish, sir. Thank you, sir. Thank you, sir.
In this World Cancer Day, we take home message is simple, sir. If we screen patient properly, according to the guidelines, we can give curative attempt more than 70%. Here, we have to highlight the things about the screening purposes. And the second one, and patient should have aware of the symptoms. What are the early signs and symptoms of the patient? Suppose the patient having the epigastric pain, they will go to the general practitioner. They will treat that it is a gastritis. You go for PPI inhibitors like ranitidine, they will prescribe. If the symptom is not resolved more than 15 days, they advise the patient to go for endoscopy. Some patient will tell, we detected the symptoms, we went for the doctors, they told only to go for this PPI. And after when they are coming means there is unbearable pain started. Then that time the patients are coming to the consultant. That time the patient is under the stage 4. Whatever if the symptom is not resolved, better to ask the patient to go for the any tertiary care centers or relevant consultant means they will detect early and they will prevent the progresses to stage 4 disease.
Correct, sir. Any symptom is not under control properly. Example, in lung pulmonology, non-resolving pneumonia, recurrent hemoptysis, despite ACT, no improvement. So we have to
work for the higher imaging ways.
Early
Like,
referral, yeah, correct.
Yeah.
Actually. Early referral is a very important tool to diagnose early, treat early, to prevent morbidity and mortality.
Yes, sir.
Thank you,
Yes,
sir. Thank you, sir. This is the purpose. That's why we do all awareness day, like the World Cancer Day, to promote all ill effect. So no fear about lung cancer, any other cancer. If we diagnose early, we can pick up and do wonders. So thank you very much. I think Dr. Madhubala Madam's slide is ready, I think. So we can start presentation of next thing. Children, any questions, Ibrahim sir or Prabhurai sir? See the chat box. Any questions you can ask our panelists.
This meeting is being recorded.
Hello,
Yes, ma'am.
can you see my screen again?
Yeah, you can open the presentation, madam. You can just open the presentation. We're not able to see the presentation, but
Shall I just proceed without the screen being there?
Your screen, madam, only thing is your presentation was not open. Your screen was very much visible.
I don't know what's happening every time it is.
Yeah, your screen is visible. I do not know if it is yours or sir's screen.
No, it is Prabhuraj's screen.
Madam, actually, what is visible in my screen? I think it's only my picture will be there. Anything else is visible, madam?
No, that's downloads is there. That ASRH.
It's like document file, ma'am. So it is not opening actually. That is the issue.
Dr. Prabhupada sir, you can try clicking the PDF file. It is a keynote file made in a Mac. So yours is a Windows, it will not open it. You can try
Okay, sir.
opening the PDF file below.
Sir, PDF is my file, sir. Actually, that
Oh,
is
sorry.
which I presented.
That's a keynote file, sir. We need the Mac
Yeah,
system
I
to
think
open
it's
it.
not. So only it's not opening, sir. Actually.
Prabhupada sir, can you mail me, sir? Sorry, I will try, sir, once.
Yeah. Okay, madam. I'll mail it, madam.
Sir,
Can you
sir,
please?
I'm Arvind, sir, Dr. Jayaraman sir's team, sir. I will just put my email ID, sir, now. Sir, this is my email ID, sir.
Yeah, one second. Okay, madam. I'll Arvind edit 1986@gmail.com. Then, madam.
till then we can any chat box we can discuss regarding any cancer related questions. You can ask our panelists. Request delegates kindly unmute your mic and you can ask the questions to our panelists, or you can type in the chat box. We'll read and we'll answer the questions.
Madam, I have sent it, madam. Madam, I have sent it.
Arvind, did you receive that? Arvind, please check. Did you receive the presentation from Dr. Prabhurai, sir?
Yes, I will check, sir. 1 minute, sir. 1 minute, I will check.
Yeah.
Okay.
You can operate from your side.
Good morning. Good morning to all panelists. I am Dr. Nandagopal here.
Sir, it's Prabhupada sir, it's asking request, sir.
Could I
Yes,
ask
sir.
the question?
Madam.
Nandu, welcome. You can ask questions.
Yes, sir. I'll ask the question. What are the results of this low dose CT screening, which was being trials were being held in US and Europe? Can this be replicated in India? Is it a feasible thing? Just a policy making? Because just now the oncologist was making a comment that most of the cancers, what we are seeing is for coming for palliation, not coming for early stage treatment. So that's why it prompted me to ask that question.
Dr. Ismail is there? So you want to take
Right,
the
sir.
question?
Ismail, sir. Sir, you can answer. No issue.
Sir, sorry
Yes,
for interruption, sir. Jayaraman, sir.
Yeah, tell me.
It's asking email request, sir.
Email request. Prabhupada, sir, how to give email request?
Sir, I don't know, sir, actually.
Dr. Prabhupada sir, can you send the mail, send it to my email ID also? I have shared it. I have
Okay,
not,
okay.
I can open and share it.
Yeah, you can try.
Okay, sir. Okay, sir. Sir, please tell your mail ID, sir.
SATHRT
SATHRT
@gmail.com.
Okay, sir. Sir, I have sent, sir.
I'll just open it. Sir.
Some of the computer is not adaptable with our meetings, like advanced computers like Mac and iBook. A lot of things. No problem.
Sir,
No
and
issue.
one more idea, sir. In Google, no, sir, if you type key file convert into PPT, it will go into Cloud Connect software, sir. So you can convert the key file into PDF.
Okay, that Satish will try now. Otherwise, Prabhupada, sir, you can do that.
On the question,
Dr.
Sir, one more chat box. I have another
Actually,
question.
the file is shared via Google Drive, not as a file itself. So the author has to give permission to
Yes, sir,
whoever is
it's
requesting.
probably
I think madam has to give permission, sir.
Only madam should give us permission to open this. Sir.
Yeah.
Sir, in the meantime, I posted one question, sir, in the chat box.
Yes.
Yeah.
Some of our panelists come to enlighten that.
Yeah. Read the question, sir.
Yeah, can you please read the question, sir?
Yeah, it's a 33-year-old female stomach cancer, stage 4, died within 6 months of diagnosis. Poorly differentiated carcinoma, 2 live children. What to do for them? Okay, like family history, maternal cousin, similar history, maternal cousin, renal carcinoma, both are in 3 decades. Yeah, so actually, gastric cancer is one of the familial cancers known to have manifest, sir. So there are actually now we call it NGS, right, sir? The next generation sequencing. We can do a sample of either blood or saliva and run it for cancer gene panel. So it will analyze for some known cancer genes, something they say more than 180 or something, and they identify the risk of cancers and quantify it. So based on the risk, we can institute a screening mechanism for them if there is a risk as per the NGS results.
NGS done, sir, in a well-known lab in Germany.
Right, sir.
All the known identified oncogenes are negative. What to do further?
Then we have to assume as we know, there are 2 causes for cancer. One is the genetic insult, that is inherited. Another is the environmental insult that can cause CA. So these particular individuals, they are likely to be exposed to the same environmental conditions also. If that is the case, the first age at the index case is at 33 years. We can probably look at assessing the rest of the family around 40 years of age to see if there are any risk for cancer, sir. Because if it is environmental, it varies from individual to individual. Not everyone will get cancer at the same age.
all the three of them living in different cities from birth.
Yeah, so then obviously there is no high risk, I would say, for this particular family, sir.
What are the investigation would you like to offer for the child of 2 years and 8 years? And
No,
when
sir.
to start screening
No, sir.
them?
CA stomach, usually we say it starts only in the middle age. So endoscopy will be the investigation of choice.
At what age we should start for these children's?
Not for children, sir. For adults, after 30 years probably. CA stomach in children is not a known entity, sir.
No, the other cousin was renal cell carcinoma.
No, those are all can be random mutations because our NGS has come negative. So it can be association by probability, not because of mutation.
In one family, 3 members, like it's like looking very odd. Looking odd.
Yeah,
all of them in the same age
yeah,
group.
True, sir. So that is why we are previously before NGS we had no option but to assume it as inherited. But now we are actually able to see the gene. There is no inherited mutation there, so we have to take it as a probability only. I understand the association is little worrisome, but as long as the genes say they are fine, they should be fine.
So should we be looking at epigenetic influences and lifestyle, sir? Because I think these children need to concentrate more on.
The most difficult thing is to change his lifestyle. I mean, it is easier said.
Yeah, said easier, but all starts at a younger age. So
yes, ma'am. Like there is no specific thing apart from tobacco. If you take risk factors for cancer, there are only 2 factors which are very crucial for majority of the cancers that we see in our country. One is tobacco, another is obesity. So what we actually say is one of the slogans is sitting is the new smoking. So if somebody is having increased body mass index, there is as much having a risk for cancer as tobacco user. So these are the 2 things probably we can look at. Other minor things we can advocate, but it is unlikely they have to be followed by the patient.
yeah, sir, I think we should all lead by example because cancer is caused by inflammation and possibly teaching children to avoid foods that are inflammatory like fried foods, food rich in saturated fat. All this will go in a long way to prevent obesity, cardiac diseases, cancers, everything. So I think the family should take an effort to look into that as well because genes are not our destiny. They means our lifestyle bigger genetic.
Only food has come down a lot now, mainly among kids. So pediatric obesity is on rampage. So a lot of people we can see, even our kids are unable to sit in the regular classroom chairs. So it's not fit to them. So we have to increase the physical activity, not only competitive sports, but regularly they should have been in some sort of sports. And even we also, even doctors also, we talk about, we preach others, but most of the time we sit continuously. We should make a habit that we take some gaps in between our OP schedule to walk and do some stretching and do some amount of physical activities to reduce our stress. We see a lot of young deaths and young MI, young strokes nowadays among our fraternity, which is really worrisome. Not only the malignancy, but other NCDs also are on the rise because of this type of
Yeah. Nowadays we are seeing a lot of NCDs, non-communicable diseases. So India is a diabetic capital now. A lot of under recognized conditions like hypertension, obesity, a lot of problems we are facing in not only in pediatric adult also. So the key is preventive. Medicine is a very, very important thing. So whichever maybe, whether it could be maybe a food factor or exercise. So regular exercise is a very important key, and awareness of all risky lifestyle habits like smoking, alcohol, and the beverages. So we need a lot of education. So in IMA we have a lot of activity committees are there to promote health awareness. So we have a Down Syndrome committee. Under this, we go to village every month and spread the awareness program, mainly the non-communicable diseases like diabetes, hypertension, and the cancer, plus obesity, dyslipidemia. And so a lot of programs. We thank our president, Dr. for this wonderful, more than 25 committee we have. So each and every committee has a very big role, task for all our patients' health to reach the village level. So we thank our president for this wonderful platform to create that. So one among the things is we have academic committee. We have a great role to spread the good messages, all updates to our members. Then only our patient will benefit. So thank you all for this wonderful, joining hands to fight against these cancer and diabetes, hypertension. So each and every month we have different topic teams, and we'll give all good points to all our members to practice easily to fight against all the deadly diseases. If we don't find out the disease early, we have a lot of morbidity and mortality. So thanks for our president for this wonderful platform to reach our people through Zoom meeting. Thank you.
Thanks for the wonderful.
Thank you, Ibrahim sir, for this wonderful team. We had a nicely enjoyed. Sudha ma'am, please let Madhubala ma'am slide is ready, or we can discuss.
I think
No
we can start questioning. The slide is not ready.
Topic, adolescent sex is very, again, it is very important topic.
One second, sir. Till the slides open, I like to just go on with the same topic. Like there was in that case, there was one history, like both the cousins had this carcinoma after second delivery. Is there any probability, any possibility pregnancy is related to this? Because we are seeing many cases postpartum, they are diagnosed with the carcinoma. Is there any correlation?
I think Ibrahim sir will agree. Pregnancy is not a risk factor for any malignancy except for this.
Yes, sir. Yes, sir. Pregnancy is not a risk factor, but pregnancy per se is an immunosuppressed state. So that will expose the harboring malignancy. So that is the only thing. We definitely see a lot of malignancies, not only gynec malignancies, other malignancies also. And most of the time, they advise to do some termination, but it is not needed always. I will tell you a case of a 23-year-old female patient with an early breast cancer. She had a primary and she was at the third month. She was third month gravida, primary gravida. So she was advised immediate termination of the pregnancy. But what we can do is we can do a breast conservation surgery and also allow the pregnancy to continue. Because most of the time they think that the chemotherapeutic drugs will harm the kid or the baby. It's not so. So I did a breast conservation surgery and the pregnancy continued. Patient continued to have chemotherapy also. And after the delivery, she had a normal vaginal delivery, male child, healthy male child. And after that, she had the radiation. And now both the breast as well as the baby are preserved. So that's the idea. That is a improvement in our treatment protocols now. So we need not terminate the pregnancy in all cases of malignancy associated with this thing. And also a lot of fertility sparing surgeries is also there. In a lot of germ cell neoplasms of ovary, we can do a fertility sparing surgery. We have got nearly 5 patients who underwent fertility sparing surgery. They resumed menstruation after their chemotherapy. They had a normal marriage and they also had 2 or 3 kids also after the surgery. So our general practitioners and non-oncologists must understand that cancer is not the end always. So I always wonder, whenever there is a diagnosis of cancer is made, immediately the next question, how long they will survive. So, but this question is not as for any other disease like diabetes, hypertension, or even for HIV also. Stigma on cancer is rampant, not only among the patients, but also among a lot of clinicians. So we need to know that there are a lot of improvements in cancer treatment, cancer management, comprehensive cancer care, where even though the patient comes late to us after having a lot of alternative treatments and all nonsense, we tried our level best, and a lot of research is going on to maintain and preserve the organ and also improve the longevity of the patient. So as of now, coming to the question, the pregnancy per se is not a risk factor, but pregnancy is an immunosuppressive state. So that can expose or bring out an underlying cancer. So that may be the options.
Yes, I fully agree, Ibrahim sir. Yeah, pregnancy is one of the immunosuppressed conditions. That's why we included the flu vaccine in the pregnancy. So overall, the vaccine, benefit means adult vaccination. We used to give 50+ all people. Less than 50, those who are having any chronic ailment, we give. One of the indications for flu vaccinations is the pregnant ladies should receive the vaccination. Flu vaccine is a very important vaccine to prevent influenza infections to both the fetus as well as mother. It will have a lot of benefit. So a lot of gynecologists are asking, Doctor, flu vaccine is it mandatory? Yes, as per the guideline recommendation from the WHO and CDC Atlanta, Flu vaccine, one of the indications is the pregnant ladies to prevent the H1N1 swine flu, etc. So I fully agree, right?
Thank you, sir. Thank you, sir.
Yes, ma'am. Sudha ma'am, please check that Madhubala ma'am slide is ready, or you can give just a oral presentation about the adolescent sex and gynae health. No issue, ma'am. Yeah.
Sir, I think Madam can present, sir, because slide is not ready, sir.
Okay.
Slides are not
Then,
ready.
yeah. Madam, you can present from your point of from your end, you can talk, madam. Sudha ma'am, you can request.
Okay, okay.
Yes, ma'am. Yes, ma'am. Yes. Sometimes this happens. Technically, some difficulty always will be there in our meetings also. No issue. No problem. You can give a oral presentation.
Okay, sir. 1 second.
Sir, at
So
this
I'm
junction,
here to talk about the adult. You want to say something, Dr. Prabhu?
Nothing, madam. Nothing, madam.
Okay. So as we are stepping into the month of March, which is the adolescent month, we are here to talk about adolescence. The adolescent is a period between 10 to 19 years where sexual maturity develops but comes in with social demands according to WHO. In India, we have a massive population around 253 millions, 1 in quarter or adolescents. So adolescence is a time of experimentation and curiosity, which increases confidence and self-esteem. It also increases the sexual feeling and impulse, and it is a stage to reproduce, and it is a beautiful period of transition from childhood to adulthood and enjoying life before responsibilities. So it is one of the most crucial periods in every individual life, the adolescent period, the teenage period, as it is said. So the reproductive health during this period is a state of complete physical, mental, emotional, and social well-being, and not merely absence of disease or infirmity in all matters relating to reproductive health system and its functions and process. So why should we focus on the adolescents? Because they are the future of our society. And this adolescent period is really confusing and stressful because of the many myths, misconception, and misinformation these adolescents are exposed to, and because of the inadequate reproductive health related information, and they are, as a group, they are neglected by the health system. We have pediatricians for pediatrics, and adolescents are not dealt in separately. So we should have special attention to this set of people. So there are many problems which the adolescent face. The first will be, as of a girl, it is a menstrual problem, which is the first stage of their reproductive life. It typically occurs within 2 to 3 years after the thelarchy, which is the breast budding. By age 15 years, almost 98% of females will have had menarche. And if by the age of 16 completed years, if a girl has not attained menarche puberty, then they have to go to a gynecologist to check whether it is normal or anything to be found out and treated. So the menstruation in adolescents and monitoring of their cycle is a vital sign for their long-term reproductive health. And they should know their body during puberty, because there are many changes which are happening during the pubertal period, and it can take 2 to 3 years from a girl's first period for a body to develop a regular cycle of normal menstruation. Usually the normal cycle is around 21 to 45 days, and the normal length is less than 7 days. If it is excess, or if it is a delayed or shortened cycle, it has to be reported to a doctor or a mother, preferably as a first instance, because a parent is the first friend and a doctor to the growing adolescent girl. The typical cycle of an adult female is 28 days, although this is not exactly as in case of teenage girls. It can be short as 21 and long as 35. So they should also be aware of their pubertal changes in their body, the soft darkish hair which grows in the vulva and under the arms. This has to be counseled and taught, and to be educated by the parents initially. And if there are so many girls living in residence schools, there should be a school counselor or a mentor to explain about these pubertal changes and not to worry or panic about these changes. The hips grow wider and become curvy. Breasts and nipples gradually grow larger and fuller, and nipples become darker in color. And of course, menstruation culminates. So the menstrual cycle, I put a graph so you will not be able to see the growing follicles and the menstruation. It is all there in the science classes nowadays, and it has to be explained properly because it is a fear of panic for the young girls who don't know much about this menstrual signs and symptoms. The premenstrual syndrome, which is a wide variety of symptoms like mood swings, tender breasts, food cravings, fatigue, and irritability, all will be there, and they should not be frightened about this. They should be counseled that it is normal because of the hormonal circulation and the circadian rhythm of the hormones. And they should avoid junk foods and salty foods and caffeine and artificial sweeteners. They should sleep enough, drink enough water, and reduce stress. And of course, dysmenorrhea will be there for some adolescents. And sometimes they can also have scanty and profuse bleeding. For all that, we need counseling. And menstrual hygiene is one thing which we have to inform and educate our adolescent girls. The use of sanitary pads and washing the genital area, which are essential practices. And poor menstrual hygiene may lead to itching or rashes in the perineal region and gives a bad odor. And why are we worried? Because this poor menstrual hygiene can give rise to complications like PID, reproductive tract infections, and urinary tract infections, which can result in future infertility and birth complications also. Nowadays, there is a lot of hype and knowledge about this dioxin, the hygiene with dioxin-free pads. The sanitary pads are bleached to increase the absorbing capacity of pads. And these dioxins are highly toxic and cause reproductive and developmental problems. They can interfere with hormones and suppress the body's immunity and also cause cancer in the. So these be educated to use dioxin-free sanitary for better
It's an honor
hygiene.
and pleasure to welcome all of you as the host for this conference. Dr. Rajesh Suleman team, fantastic work in organizing. I can see.
I request Dr. Aravind, Mr. Aravind, kindly mute that mic, ma. I request all the delegates kindly mute.
I hope whatever you say.
So it's better to educate our girls to use dioxin-free sanitary pads for better hygiene. And there are lots of adolescents who are unaware of menstruation. What is menstruation? How to deal about it? Should be always informed prior, even from their 5th standard. This has to be educated because of the long-term reproductive health consequences they will have regarding the awareness of menstruation. Girls who have been educated about menarche and early menstrual symptoms will experience less anxiety in the future. And coming to dysmenorrhea again, it is 50 to 75% of young women begin to experience painful menstrual cramps. But mostly we say up to 16 or 18 years, it will be a anovulator bleeding and there will be no pain during menstruation. But nowadays we are worried about the early onset of endometriosis in these young girls, and some cases of dysmenorrhea are eventually traced to endometriosis. In previous days, mothers and grannies used to say, Kalyanam kazhinja ellam unakku seriyaidum, vali ellam poidum. That we cannot be telling our young girls again. The days have changed, and we have to look into the dysmenorrhea as a real symptom. And if it is nothing being found out, it is well and good. We can counsel them. But something is the early onset of endometriosis. We see a lot of adolescents coming to the OPD with severe pain, and only with the endometriotic treatment they are good. If you are leaving them like that, they slowly develop into endometriotic cysts, which will definitely a big thing in their future reproductive health. And but majority of girls should be reassured that the cramping is related to the release of prostaglandins, which can be easily remedied. And one more thing they will face during this adolescent period will be the dysfunctional uterine bleeding, which is heavy and irregular bleeding. And heavy or irregular bleeding is a hallmark sign for anovulatory bleeding during adolescence. But that can be sometimes an underlying medical problems. One girl had come with last week, or every time, again and again, we are seeing such patients, is obese girl around 95 kg, which is she was in 8th standard. And she was complaining of giddiness, vomiting, and heavy bleeding every time during her menstruation. She had attained an early menarche also from the 5th standard. So incidentally, when we looked at her BP was 190, 110, and when we checked everything, she was having a early renal failure. That was such a shock to the parents and even to us. So any DUB, we have to evaluate it properly. Gone are those days when we say Yeah, this is normal in adolescent period, but nowadays we have to look at everybody into what problem they are having. If it is normal, we are also assured, the family is assured, but otherwise we have to give them a proper treatment. And if not for any other grave disease, as I've explained just now, that when not treated, the heavy bleeding can also lead to severe anemia. And one common symptom what we are all seeing nowadays is the polycystic ovarian syndrome, even early in the adolescent stage, because of the obesity and the lifestyle changes which they are not willing to adopt in this early days. So it's a common health problem, and of course, the adolescents and PCOS is such a challenge to diagnose PCOS during these times because they both overlap each other. The symptoms of polycystic ovarian disease and the normal symptoms of adolescent, they overlap. The menorrhagia and increased acne and everything will be there in PCOS, and also it will be there in the adolescent cycle. The normal pubertal development, they overlap. So it can cause irregular menstrual periods and or heavy periods or even amenorrhea or no periods. The androgenic features like acne, thinning of hair, and obesity all relate to PCOS, and sometimes it is also there commonly in the adolescent cycle also. We should also explain to them about the hormonal imbalance and the insulin resistance with obesity, and the extra weight which is concentrated around the waist, and the hirsutism, thinning of the hair, acne, and clogged pores. Acanthosis nigricans, which is a velvety patch around the neck and the underarms, and even under the breasts, and sometimes even systemic diseases like high blood pressure, high cholesterol, and diabetes mellitus. If there is obesity in young girls or young boys, it is the general practitioners, and of course wherever the adult is being dealt with, adolescent being dealt with, should be educated about the lifestyle changes, because these are our future adults and they cannot be getting into early grip of any grave problems in their adulthood. So early detection of PCOS is very important, and girls who show signs of puberty early, such as developing underarm hair or pubic hair, even before the age of 8, are at greater risk of PCOS. So the recognition of early signs of PCOS is of great importance for the reproductive health. And with correct diagnosis, we can rule out the other causes of excess androgen and also help to reduce the complications. Coming to the nutritional deficiency, we should always say, we should advise them to say yes to milk and milk products, curd, paneer, green vegetables, fruits, cereals, soups, juices, regular meals, and a balanced diet with good proteins and fats. It is better to ask them to avoid junk foods and the packed foods. And fish, lean meat should also be encouraged. Most of the times, we see people cornering around these junk food places every Sunday. Even today, when we look at the KFC, which is just opposite our place, I can see cars just coming to the roadside. Also, there were queues of cars standing in the KFC. When you peep into KFC, you can see only adolescents and small girls, and the parents along with these kids are there in KFC with this for the fast foods. That is the craze of fast foods nowadays. So the important area which needs attention is again and again nutrition, and inadequate nutritional intake during adolescence can have serious consequences throughout the reproductive years and beyond. And these girls, when they enter into the adulthood, the malnourished and anemic women among the adolescents are at greater risk of maternal morbidity and maternal mortality. Anemia, which is a state, Indian women are almost, they say 85% they're anemic. This is a state where there's a decreased production of red cells or there is a decreased concentration of hemoglobin. And we have a red campaign in Foxy in the first 2 weeks of March. So we are doing this HB hemoglobin campaign for all of our patients. And also if extended, we can extend it to all the schools. +2 and the 10 students should have all their hemoglobin checked. +2 students, they should have a hemoglobin of 12 grams, which should be encouraged by the school counselors and the mentors and of course the parents, because there's a very, very poor intake of iron in our group of girls and well as boys. 7 out of 10 girls may be anemic during teenage, and it is that common. And that is why they suffer from tiredness, lack of concentration, hair loss, and irritability. We can always see girls accompanied by their mother saying, "Mudugu valikkudu, kai kaal valikkudu." I'll be wondering why at this age they should be having all these things because of anemia. Because when you take the list of the whole of list of one day's diet, you can hardly see much of proteins and iron in it. So how come they can have good iron when they don't concentrate on a good diet? So the dietitian's role also we have to play as a gynecologist and obstetrician. When these girls come to us, we have to have a multiple roles, not only as a gynecologist, we have to be as a nutritionist, we have to be as a physiotherapist, as a counselor, as a mentor, all these things. Only then if you're friendly with your patient, adolescent patients, they will be friendly with you and they will open out their problems in towards you. Otherwise, they'll be just sitting and watching you and they just walk off as you write your prescriptions. So the iron deficiency anemia is of course a vicious cycle. This adolescent enters the reproductive age group with a low iron stores and she becomes pregnant with anemia and she gives birth to a baby with a low iron content and hemoglobin levels. Again, this anemia is carried on into childhood uncorrected. And again, she becomes an adolescent, he or she becomes adolescent with a low iron and HB level. And if she is a girl, again with a menstrual loss, she again enters the adolescence group with a low iron store. Such a vicious cycle, we have to break it. Otherwise, we will have more of morbidity and mortality. So we have to teach them what are the iron-rich sources like the fruits and vegetables, spinach, broccoli, carrots, milk, lean meat, fish, if they are non-vegetarians. And even for 18% of boys are anemic and they have to be also treated. Only girls is not the only adolescent we are saying, it is also the boys. So we have to be taking care of the boys also. So the perpetuating a vicious cycle of malnutrition and ill health because of anemia should be curtailed and should be educated initially, mainly to the parents as well as to the girls and the boys to prevent anemia in the future. And the junk foods, which is causing a very great havoc in reproductive health, that is because these foods have phthalates. Phthalates are chemicals that may disrupt the body's hormonal activity. Maybe it's a boy or a girl. And this exposure to such high levels of chemicals can cause various reproductive problems. Then comes the obesity and the lifestyle. Prevalence of obesity in adolescents continues to increase in the last 20 years. Changes in lifestyle, which include consuming foods and beverages, increasing the food portion sizes, decrease structured physical activity, and increase screen-based sedentary behavior. As a last, seen lots of our kids sitting and watching our iPads and mobile because of COVID, and that has become and continued as a habit even now. And that has influenced the prevalence of obesity. I had all these beautiful slides of junk foods, and then I'm sorry that you people cannot see it. All these junk foods like parota and all these junk foods should be asked them to avoid. Maybe they can do it once in a month as a treat, not as a regular basis. We can see every weekend this junk food shops being crowded by our teenagers. So obesity in adolescents, what does it cause? It can cause amenorrhea, heavy menstrual bleeding, and obese adolescents, when they turn into adult pregnant patients, they are at increased risk of cesarean delivery, very difficult labor induction, preeclampsia, and gestational diabetes. We have to tell them how important is exercises, and they have to choose an outdoor game as a hobby like badminton, football, volleyball, and always get involved in school sports. They should not cut down their sports classes and go for other career based classes. And maybe they can take into dancing classes for tuitions, cycling, swimming, jogging, or even a brisk walk with their adult parents can also help to maintain fitness. We can also tell them to avoid elevators and walk upstairs, avoid bus and car. They can also take up swimming or any small kickballs also they can play at home. Even yoga, if there is no place, I cannot send my beti or daughter outside, then they can go for yoga classes also. Even nowadays, online yogas are preferable and they also teach very good yoga, but we have to be perseverant. The girl and the boy have to be stubborn in doing this yoga classes also. Then comes the reproductive tract infections, which about 15% of adolescent women reported having any symptoms of infections. And silent epidemic, RTI, reproductive tract infections, is becoming a silent epidemic among females, which contributes to gynecological morbidity and maternal mortality. And some reproductive tract infections can spread to the uterus and fallopian tubes, causing PI, which lead to infertility, ectopic pregnancy, cervical cancer, fetal loss, or infant health. We might have seen lots of women coming to us married 2 months, 3 months with ectopic pregnancy or infertility after 2, 3 years, but they'll always ask, I have been not been having even one episode of fever. Why should I have all this infection? If there is a tubal blockage also, we will say some PID is there. How come I can have PID? எனக்கு ஒரு காய்ச்சல் கூட ஒரு நாளும் வந்ததே இல்லையே, எப்படி எனக்கு மட்டும் இன்ஃபெக்ஷன் வரும்? But this can be a silent epidemic with a poor menstrual hygiene also, we will never know. So right from the grassroots level of 5th standard or 4th standard, we have to teach them what is good hygiene and sanitation, which is very, very important for their future reproductive health. Vulvovaginitis nowadays, I've been seeing lots and lots of adolescents, mostly people living, girls living in the adolescent, what is that, residential schools and hostels. They come with characterized vulvar pruritus, irritation and burning with vaginal discharge. And we have to explain to them how important is the sanitation, how to use this panty liners, because most of our girls, almost all the girls are using only pants and not the skirts nowadays. As we are living in a hot tropical climate, they have to wash the perineal area, and we don't have the habit of drying it with a tissue, and that's why the humidity and the moisture stays there, and it will invite infections, thereby pruritus. And moreover, there is a hair growing area, and that has to be kept clean or clipped, and that everything has to be told and explained and educated to the adolescent. Otherwise, who will tell them? They will not, they cannot learn everything from the web. Sometimes web is not allowed, internet is not allowed to these young girls. Parents or the student counselors or the doctors, at least, we have to educate them when they come to us. We cannot judge and then write a prescription and send them away. We are in a responsible position to educate them what is a good sanitation of the perineal areas too. So bacterial vaginosis, trichomonas are common. Bacterial vaginosis nowadays is very common because of the common usage of toilets and non-drying that areas properly. They have whitish to grayish vaginal discharge, which has got a malodorous, fishy smell. And this is a main important cause of PID and predispose these adolescents to other reproductive tract infections also. So recurrent BV or bacterial vaginosis has been documented rates between 30 to 50%. They have recurrence. And of course, urinary tract infection, that because of the vaginal colonization of nephrogenic strains of bacteria, they migrate to the periurethral area and they cause UTI. So UTI, when they have poor self-esteem, they will just confine themselves to one place. They'll not talk to others. Social isolation will be there, and they'll be depressed. Only when it is brought out and cured, it will be treated properly. So the UTI can be due to inadequate hydration, lack of clean toilets, and poor menstrual and sexual hygiene. Most of our schools, we always think as a Foxy, in our Foxy, that we have to approach the schools and tell them to have good sanitation in their toilets. Sometimes the girls used to say, I don't go to the toilet only when I go home. When I come from home, I'll go to the toilet, and then only at 4 p.m. I go home and go. I'll ask why. They say, there will be lot of crowd in the toilets and I cannot be just standing. By the time the bell will ring and I have to run back. So, and there will be a lack of cleanliness that also make so many girls inhibited to go and use the toilets. So there is a need to educate our girls regarding good hydration and hygiene, and of course the school authorities also to be educated. And recurrent and chronic UTI can also damage the kidneys. So we have to be very careful. Hence, they have to be treated promptly and diligently. Early and forced marriages, child marriage is again common and elsewhere, not maybe not that in Tamil Nadu, but other places of India, it is still there. And primary causes of adolescent girl deaths are mainly due to the pregnancy and the childbirth complications. So adolescent mothers, when they get married at the age of 18 or 19, they are at a higher risk of eclampsia, puerperal endometritis, and systemic infections. And babies of these adolescent mothers face higher risks of low birth weight, preterm birth, and severe neonatal infection. So we have a sustainable development goals, and one such is preventing adolescent pregnancies for achieving positive health outcomes across the life source, and imperative for achieving this goals, which is related to maternal and the newborn health. Coming to the contraceptives are very important thing to be discussed with our adolescent group of girls and boys, because our contraceptives in India is not very easily accessible, and maybe very much also. Even when adolescents can obtain, they are often at a higher risk of discontinuing the use due to side effects and due to changing life circumstances and reproductive intentions. And of course, we have to deal with the emotional changes, which is very difficult from when they are having a transition from childhood to adulthood. They will have different attraction fantasies and mood changes, which is irresponsible, stubborn, and search for identity and sexual development, which will create a sense of crisis. They always compare themselves with their adult parent or adult any other person, and they'll try to mimic, and they become very stubborn during those times. Smoking and alcohol and drugs are poisons, and they should stay away. They have to be educated about it. And there one word on spirituality. Unless we develop the spiritual side of our nature, society cannot combat the evils that plague the society. So morality, justice, truthfulness, love, sacrifice for the common good, peace, and discipline is the need of the hour. And honesty, tolerance, and care for the challenge should also be educated to the adolescents. They have to have everything in them as they grow into a good and a perfect adult. And they have to say no to stress, because they have stress from all sorts of sides, from the peer group, from the education side, and from the family side. And that is an important aspect of spirituality when they have a moral decision making. We have to advise them to be being humane to fellow beings, and these qualities always come through the parents. A word on the violence against women prevalence. Sexual abuse increases the risk of unintended pregnancies, and sexual abuse, the effects will be multiple and long lasting. The physical consequences which will be there include STDs, HIV infection, unwanted pregnancy, miscarriage, unsafe abortion, and difficulties with interpersonal relationships, homicide, and suicide. So these adolescents, when they get into unsafe sex, they can have abortions, and the risks in abortion would be they can go to a quack or ill-qualified person, and the abortion can be incomplete, which may also lead to surgical abortion, and that might also lead to PID and a future blockage of all the reproductive outcomes to this adolescents. And ongoing pregnancy, if it doesn't completely get ridden off, then they can have heavy bleeding, prolonged bleeding, infection, fever, and even septic abortion, and mortality can also rise. When the last panelists were talking about all the adult cancers, I have to give a word on the vaccines for the young girls, which will be rubella infection to avoid the birth of a child with a defect, and cervical cancer, which is because of the HPV virus. Have you ever seen a child with defect, and why should it happen? Why should it happen? It is almost 10 lakhs per birth per year having a congenital defect in India. The children are born with that. Maybe blindness, maybe heart defects or mental retardation or deafness. And of these, 21% is due to rubella. Coming to the cancer vaccine for young girls, this has to be educated to our young girls, and mainly to the parents and schools again, and the colleges, because the HPV vaccine is the main cause of culprit for the cervical cancer, and India ranks almost second in the world population for cervical cancer. When we recently met at Eurogen 2023, yeah, conference, especially for the human papilloma virus and the cancers of the reproductive tract. We were very much embarrassed to see only 3% of the Indian population, they are aware of the HPV vaccine, which is prevalent all over in India. So we have to educate. We all had taken a vow, like in that conference, that we'll propagate the cervical vaccine too much in our place. Only when we start from the grassroots levels, it will just spread like to the state and to the district and to the state levels. So HPV vaccine is to fight against the virus called the human papilloma virus, and usually occurs due to sexual exposure and contribute 99.9% of the total cases of cancer cervix. In India, 27% of deaths is worldwide due to cancer cervix, and higher prevalence and death than any other cancer in India among the women, which is on the increase. So we have to protect our women. We have to educate our people. As they usually, what do we do in our clinic is, as they give birth to the girl child, then we will give them a gift because it is a girl child, and then we will tell them this is a girl child to be protected. And during your adolescence, as you come through the vaccine phase till the 15th year, at the 15th year, you have to have another vaccine, important vaccine called the HPV vaccine. And we can also give the same HPV vaccine for all the mothers who have delivered. Even after delivery, there is no point in taking a test and then saying whether they are whether they are harboring HPV infection and later giving HPV vaccine. It is not at all needed. Every woman till the age of 45 can be given a HPV vaccine. That's how much ever it is protective, it can be protected. It is better than none. So we have to protect our women against the cancer cervix. And this facts about HPV infection is, for the first year, it will be just an infection. And of the next 5 years, it will be a low grade cancerous lesion where there will be minimal symptoms like then in 20 years only it will go for an invasive cancer, and then the symptoms here. So we have got a beautiful 20 years of period where we can protect our women even with a low grade cancerous lesion. When we give a HPV vaccine, this woman will not progress to a high grade cancerous lesion. So HPV vaccine at any point of time from 15 years, when it is given earlier, then that's the best before marriage. But even not otherwise, we can vaccinate all our women even after delivery, marriage, get into the pregnancy and other things. So safety tips to the adolescents, we have to be careful about the good and the bad touch. Nowadays, so many short films have come and so many documentary films have also come for their thing. And sexual abuse, they have to be very much careful. They have to, they should not allow anyone to take pictures in a sexual way or touch the body in a sexual way, and you have to ask them to stop or take pictures. Nowadays, because of the selfies and other things, they just propagate in Instagram and Facebook. They have to be very careful in posting their pictures. And one last thing will be the suicidal tendency, which is becoming very common in the adolescents because they cannot take anything negative. They have to avoid stress, and for this they have to be very friendly with their parents, or parents should be very friendly with their teen boy or a teen girl, and they have to discuss any problem with the teachers or the parents about any personal problems other than friends. Friends can misguide because they are also an adolescent boy or a girl, and she or he can misguide the other person into wrong things. So the any problem should be discussed with parents or teachers or their mentors, and they should not decide anything in anger, because we should always teach your adolescent, when you're in anger, sing a song or count from 1 to 10. By the time your anger will be reduced, and then you can decide clearly. Of course, adolescent pregnancy and abortions, and say you have to inform about the serious complications and definitely about the contraceptive methods, rather than going for emergency contraceptive, like coming and running to us with for emergency contraceptive. If they are sexually active, we have to tell them about the contraceptive methods and explain how pregnancy occurs in which situation. People will think that only hugging and kissing can cause pregnancy. We have to educate the teens that how pregnancy occurs, and they have to be careful about it. And they have to have some needed life skills. They have they have to accept the success and also more about the failures. We have to accept it. And life without a goal is like a ship without a rudder. And they have to learn a game or an art, and they have to be very passionate about the life, and they should not have any negative defeatist attitude, and that they should avoid it. I had a beautiful picture of Abdul Kalam saying, success is when your signature changes to autograph. And adolescent health is our nation's health, and let us resolve to take care of this adolescent's health as a group of medical practitioners, not only obstetricians, gynecologists, be it a medical general physician, general surgeon, whoever it might be, an oncologist. And when adolescent comes to you, we have to educate him or her according to our knowledge. And thank you all. And I'm so sorry that I could not display my slides. Thank you all for the patient listening and the time given to me. Thanks, IMA, for this wonderful opportunity.
Thank you, madam, for giving us an overall view of all the adolescent problems, right from the common problems to mental health. So though the slides were not there, your talk was very clear and could relate to whatever you spoke about. Thank you, madam, for your presence and your time.
It's my pleasure. Thank you.
Thank you, madam. If there are any questions, you can post on the chat box, or if you would like to ask madam, then you can unmute and ask.
Can I ask a question? Like in your experience, over the past 10 years, what is the impact of social media and the, what do you call, the lifestyle of adolescents and the health issues of the adolescents? Thank you.
So social media, maybe they have taken the life issues or taking the films or other things, but health issues, I don't think. They have gone into too much of unwanted things, and they come and ask us about the why discharge, and without even having a proper knowledge, they take something from the YouTube and Google it. And definitely last 2 years that had made a very great impact, because that has been a must for all the adolescents to have some form of mobile or laptop into their in their hands, and they come and ask all questions, which might feel silly or here silly to us, but we have to educate them in a very good way, that this is not the point you are telling, and this is something else. It is as for reality, it is something else. We have to educate them. Social media has caused too much of opposite sex fantasies. I have recently, the girl was delivered by me around 17 years back, and she's in +1. And the family is so known to me, and she's such a polite and loving girl. Last 2-3 months, I've been getting a call from her father saying, after this COVID, she has been on Instagram on and off, and her sister is saying that she's talking to a boy. So these parents are from Satangulam village from Tirunelveli, quite away from Tirunelveli. And they used to call me for each, and because it was a precious pregnancy when they delivered it. So they were calling me for all these things, and I used to tell them what all advices I can give them. I had given them, like call her and talk to her. Such a wonderful girl she is. Even when she comes to me, she'll come with a chocolate. Every time, I'm very happy to see you, madam. Like that, she'll say. But I cannot expect the same behavior from her father saying all these things. So I said, if I talk, then it might be relevant to her that you have called me and talked to her. ஸோ அவளை கூப்பிட்டு கொஞ்சம் நைட் எல்லாம் உட்காந்து பேசுங்கன்னா, ஹீஸ் டெல்லிங், அவளை கூப்பிட்டு பேச்சு ஆரம்பிக்கிறப்ப இதை பத்தி தான் ஏதோ பேச போறீங்க. ஸோ ஐ கேன் நாட் டாக் டு யூ. இது ஒண்ணுமே உங்ககிட்ட பேச முடியாது. ஷீஸ் பிகம் சோ ஹார்ஷ், and you cannot imagine how she's behaving. And then what they did, I made it a point to go to a psychiatrist or a psychological counseling. The patient didn't come, the girl didn't come, but only the parents went, and they had given some tablets. Mostly it would be sleeping tablets, nothing else. And the girl has not changed. She is stuck onto the phone, and she's been throwing phones, or if the phone has not been given, she will throw it, take a fight, and she'll break everything in the home. Those tantrums are there. I don't know how to treat that girl. Even now it is a problem. Even 2 days back, I had a call. She has broken the TV in her house because they didn't give that Android phone. So the social changes, they have gone to their school as I advised, they have talked to the headmaster, they have talked to the teacher, nothing has helped. The girl is very silent at school, and when she comes back home, she throws all her tantrums at her parents and all the objects. I don't know how to educate the parent and where to go and ask them. Even they had given some tablets from the psychological counselor, but nothing helped. This is how the scenario is, and I cannot even imagine that small child is doing all these things. That is how she is now. What would you do at this instance, sir? I don't know what else to, because I am so you cannot be so emotionally attached. But that girl I've been seeing her from a childhood. Now she is in +1. I cannot imagine her doing all those things. There are lots of instances. Other girl had become so depressed because she didn't go to school for 2 years. Then I called her counselor. In another 2 months, the school will open. Then the school got again delayed for 3 months. Then again they'll come. I had counseled them again and again because she had missed her friends. And again, she was throwing tantrums because everybody went through the same scenario during the COVID. So a lot of changes, and I don't know, Facebook and YouTube, how much impact it causes. I don't have much time to go to the Facebook, and I don't know how the adults and the adolescents, in spite of their school timings, they have time to get into this Facebook and Instagram.
Thank you, Dr. Madhubala ma'am. Wonderful talk on adolescent sex and the gynec health. This is a very important subject, very important project of our IMA. That is Mission Pink Health under the Women Doctors Wing. So we do a lot of school health program, college level program to teach all about the menstrual hygiene, everything aspect. So you are wonderfully, beautifully enlightened all the details in and around about the, including vaccinations point of view, everything. So we had a very a wonderful time. So thank you very much, Madhubala ma'am. Any questions? Please, I request delegates unmute and will ask questions.
Madam.
Otherwise, we will go for the final vote of thanks by Dr. Nandagopal.
Madam.
Yeah.
Madam, can you please enlighten about the role of HPV vaccination for males?
Yeah, now this HPV vaccine, now there is a vaccine called HPV-9 from Gardasil 9. This is becoming the highlight for adult males also, because the risk of oral cancer, anorectal cancers, and all these cancers are related to HPV nowadays. And all the males, right from that 15 years, they can be vaccinated with this HPV-9, which is advocated mainly for the boys as well as for the girls. So that was the latest Eurogain 2023, which was held in Spain. That was the highlight in all these countries throughout the world. They were highlighting it on the boys, adolescent boys, who have to have this HPV-9, because the sexual promiscuity is increasing right from their adolescent age in almost all the countries. And we should not be surprised it is happening even in our place. But it is their right, they say, because even our point of view, the abortion council has made it like you cannot ask them whether you are married or unmarried. You should ask them who is your sexual partner, and you have to advise them how many sexual partners you have, and accordingly you have to advise them. You cannot just command them or do anything. So HPV vaccine is a must for our boys and girls. HPV-9 is available, though it is costly, but it is for our future prevention of cancer. We have always stepped forward for this HPV-9 cancer.
Thank you, ma'am. Thank you, ma'am. Thanks a
I
lot.
think Western countries, HPV vaccine is equally offered for adolescent girls and boys. Here in India, I think at present the scenario is we are trying to offer for girls, and India is producing its own indigenous HPV vaccine. Soon, I think it will be only costing about 200 to 300 rupees. It will be rolled out in another 3 months, and Government of India is planning to vaccinate about 25 lakh girl children with this HPV vaccine, is what we recently heard. Thank
It
you.
is all started in Ahmedabad. They have started the 200 people, girls have got vaccinated, our indigenous vaccine. And the reports are yet to come in other things. They are going to launch in 5 states now, initially. And if that is available, cheap and welcome, and we should be inculcated in our national vaccine program for the girls as well as the boys.
True.
Good afternoon, everyone. I should say wonderful congratulations to all the speakers and the Madhubala man and all the panel of oncologists who made it so lively. And most importantly, the audience who stayed till the end, although it overshot the program by almost an hour due to a technical default. All the people, there are 82 people still now, that says great about the audience too. Thank you, everyone. Thank you so much. We look forward to meeting you next month, last week. Thank you.
Thank you, Nandu. Thank you very much for the wonderful moderation and the word of thanks, everything. So kindly note, we have this program is accredited by TNMC Medical Council, and there is you can enter your name, email ID, and the mobile phone with the registration number in the chat box. They can apply within 3 days time for the credit points. So this is the account you have to pay the rupees 100 through this online account. Indian Medical Association, AMS, account number 75260100001890, Bank of Baroda, Delhi branch. IFSC code is BARB0 THENIX. So send the transaction detail after the screenshot to IMA@tamilnadu@gmail.com within 3 days of CME. So last month CME, already we got all the CME credit points just 5 days back only. So I request everyone within 3 days apply these credit points. So thank you very much. We'll meet again next month with a wonderful theme for the day is called World Sleep Day. So this day we are going to have a very good panel discussion. So request Dr. Nandakumar to moderate this event. Thank you very much. Have a nice day. God bless you. Thank you.
Thank you, sir. Thank you.
Thank you very much. Thank you, madam.
Thank you, sir.
Thank you, sir. Thank you all. Thank you.
Thank you, Vijay Kumar sir, for our IT chairman for this wonderful Zoom platform, for the providing us to give knowledge sharing to all our members. So thank you, Vijay Kumar sir. He's IT chairman of our IMA TNSB. Thank you, sir. Thank you very much.
Thank you, sir.
Thank you. Bye, sir. See you.
Thank you, sir.